So,
And
Ashok sir, we are live
Yeah,
with the audience, sir.
okay. We are live.
Yes, sir.
Yes,
Good morning from FOGSI ICOG. I once again welcome you to all for this month ICOG PG clinic. And this is a great moment today. We have completed 4 years. We have exactly in July month, 4 years ago, started this program when Dr. Uday Thanawala was the chairperson of the ICOG. After that, chairperson of ICOG, Dr. Lakshmi Shrikhande, and then Dr. Parul Kodawala, and presently Dr. Parag Biniwala is the chairperson of ICOG. Under their dynamic leadership and their support and coordination, we are doing this program over the last 4 years. And we are thankful to FOGSI President, all previous FOGSI President and presently Dr. Sunita Tendulwarkar for supporting us in this endeavor. We are thankful to our Secretary General, Dr. Suvarna, and obviously our Secretary, Dr. Sarita Bhale Rao. She is also very cooperative and supportive for our program, and Vice Chairman elect, Dr. Sheila Mane. She is also very thoughtful of continuing this program, and we hope that next year also we will be continuing with this program. So today, as you know, we do this program on second Sunday of the month, and today is the second Sunday of July month. In the morning, 11:30 a.m. Today we are having very impressive faculty who will be giving lot of knowledge and lot of information to our participants. They are all experienced teacher, and we will be starting with the doll and dummy, as you know. And today, Dr. Arup Kumar Maji from West Bengal, he will be talking about fetal skull and maternal pelvis. He will demonstrate everything. And then we have an important case discussion on endometrial carcinoma, where Gujarat Cancer and Research Institute, Ahmedabad, faculty Dr. Bijal Manish Patel, professor in HOD, she will coordinate, and her students will present the case on endometrial cancer. And Dr. Ashish Mukhopadhyay, as usual, Dr. Amita Suneja from Delhi, Dr. Sunesh Kumar, another expert and great teacher from All India Institute of Medical Science, New Delhi, Dr. Bhagya Lakshmi Nayak from Cuttack, and Dr. Dipanvita Banerjee from Kolkata. They are all oncology experts, so they will be discussing the case with the students. And I hope after today's discussion, the students will have more clear picture and understanding of the case. And in the end, as usual, we will be having master the technique, and this is a skill-based learning. And we thought we should have a demonstration and talk by pathologist. So Dr. Divya Midha will talk about the changing landscape of endometrial carcinoma, what are the different pathologies of endometrial carcinoma. And in the end, as usual, from this year, we have added the quiz. And our chairperson, Dr. Archana Kumari of FOGSI's quiz committee, she will conduct the quiz on endometrial cancer. And uh, with this program, I welcome all the faculty, and I am thankful, and ICOG expressed its gratitude to all of them for sparing their valuable time uh, from their busy schedule. And we have now Dr. Parag Biniwala also with us, Dr. Chairperson of ICOG. Now I request Dr. Parag Biniwala to say a few words.
yeah, thank you, Dr. Ashok. Good morning, all. I bring greetings from ICOG, and it's indeed a pleasure to be in the PG clinic program. At the outset, let me compliment Dr. Ashok Kumar, Dr. Hafizur, and Dr. Ashish, who've been conducting this program for nearly 4 years. Special thank you to all our teachers today. Thank you, Dr. Arup Kumar Maji. Pleasure to have Dr. Amita Suneja, who is recently completed her visit to Ludhiana as ICOG visiting professor. Thank you, Dr. Amita, for being here. And of course, Dr. Sunesh Kumar and our own Dr. Bhagya Lakshmi Nayak. Thank you very much for sparing your time. Today's session is definitely going to be interesting because as a common gynecologist, nowadays we are seeing a lot more endometrial cancers in private sector in Maharashtra than even cervical cancer. So it is really going to be interesting to learn from people who are here who have worked in the field of oncology for last so many years, and I'm looking forward to the exciting session. So thank you all for being here with us today, and let's have a good learning session. Thank you very much.
So thank you, Dr. Parag, for your exciting and stimulating words. And we are hopeful that we will continue this program in future also. Let me remind you that the recording of all these programs over the last 4 years are available on the ICOG website, and you can visit the website and go through the learning which we have done in the past. And in the last but not the least, I would like to express my thanks to my colleague, Dr. Hafizur Rahman and Dr. Ashish Mukhopadhyay. They have also done very hard work and coordinated the event every month for the students. So thank you all. Now let's begin the program, and I invite Dr. Hafizur Rahman to carry forward. Dr. Ashish will join a little late, and we hope that we will have his uh, he will also share his knowledge with us. So, Dr. Hafizur Rahman, please continue.
Good morning, everyone. Thank you so much, Ashok sir. So, as Ashok sir said, that is, we have completed 4 years. So, we started this programming in 2021, 11th of July. So now it is 13 July 2025. So we are in the 5th year. And as sir said, we have different chairperson of ICOG. Along with that, it was very important that is we have so many FOGSI presidents who have unequivocally supported for this academic program. So initially in 2021-22, Dr. Shanta Kumari was the FOGSI president when Dr. Uday Thanwal Srinasar, this was started. Then we have Dr. Hishikesh Pai in 2022 and 23. And then 2024, Dr. Zaidip Tank, sir, and presently 2025, Dr. Sunita Tandalatkar, madam. So everyone supportive for this program has been immense for continuing this program. So along with that, as all the chairperson of ICOG and Dr. Ashok Kumar sir and Dr. Ashish Mukhopadhyay has been instrumental for continuing this program. So we'll have this today as we are continuing with for the postgraduate student, that is fetal skull and maternal pelvis. Today we have on occipital posterior position. So it's expert in vastly experienced Professor Dr. Arab Kumar Mazhi sir will be having this on this session, and followed by the case discussion, which I am sure will be one of the exciting, because I had got many requests from the students from that is they wants to have a case on endometrial cancer for better clear understanding. So I am very much thankful for Dr. Bijal Manish Patel madam for sparing our MCA students for this academic program. So Dr. Radha Gupta and Dr. Srikant will present a case, and I'm sure it will be interesting. And we have so many vastly experienced faculty. Dr. Ashish will join a little later. But as Dr. Amita Suneza madam is professor and former principal and UCMS and HOD of VJNS, GTB Hospital, Delhi. Then we have so much experience, Professor Dr. Sunesh Kumar sir. Sir was the former professor and HOD at AIMS, New Delhi. Then we have another experienced faculty on gynec-oncology, Dr. Bhagya Lakshmi Nayak. Madam is professor at Acharya Harihat Postgraduate Institute of Cancer, Cuttack, Odisha. And we have again the Dr. Deepanita Banerjee, that is a young energetic gynec-oncologist from CNCI Kolkata. She is also there in the discussion. We wanted to have for the postgraduate students for better understanding of different types of pathologies of endometrial cancer. So we have request Dr. Dibya Midhya. She is the oncopathologist at Tata Medical Center, Kolkata. She's also there for having some demonstration and clear understanding for that, followed by the quiz session. So now I would like to request Professor Arup Kumar Mazhi sir to have a better understanding and demonstration for the postgraduate students, which is a basic thing in DAMI and all, to have a demonstration of principles of management of labor and mechanism in occipital posterior position. So over to you, Arup Kumar Mazhi sir.
Good morning, everybody. This is a very interesting and common topic on occipital-posterior position. I would like to demonstrate with the doll, fetal head, and the dummy pelvis. Now, just see whether it is visible, Dr. Hapiju. Well,
yes, sir. It's
Yes,
perfectly
yes.
visible.
that is the angulation.
You
So-
can, it's a little bit of backward, sir, or you can push the camera. Yeah, sir. Yeah, perfect, sir. So you can keep yours.
So at the very beginning, we will show the pelvic inlet and the different quadrants and the segment. As we know, traditionally there are the four quadrants. One is the left, another left anterior, another is the right anterior, and another is the right posterior and left posterior. But subsequently, it was found the position is not limited to the 4. It is actually the 8 position. So it was divided in the 8 segments with 45 degrees. One is the left anterior, one is the direct anterior, the right anterior, right occipitolateral, right occipitoposterior, and direct occipitoposterior, left occipitoposterior, and the left occipitolateral. And of these, the occipitoposterior is called actually position in the occipitoposterior when the fetal head lies present in the occiput lies in the posterior. So the right occipitoposterior and left occipitoposterior and the direct occipitoposterior. The direct occipitoposterior primary is very uncommon, very uncommon. The total occipitoposterior, it is about the 10 to 11%, and in a few circumstances it may be higher according to depending upon the type of the pelvis. And all of you know the maximum presentation occurs is actually the occipitotransverse, and right occipitoposterior is more common. So occipitoposterior is, we see this is the right occipitoposterior, this is the direct occipitoposterior, and this is the left occipitoposterior. And then we'll come to the fetus. Just recapitulate the fetal diameter so that you have good idea about the what presentation and what diameter will come in the occipitoposterior. Now you can see this is the fetal head. This is the fetal head, and this is the occiput, and this is the sinciput, and this is the lambda suture. This is the lambda suture, and this is the posterior fontanelle, and this is the anterior fontanelle, and there is a sagittal suture. And the vertex presentation means it is the quadrilateral area. It is just like recapitulation. The quadrilateral area bounded anteriorly by the anterofontanelle, the coronal suture, and posteriorly by the lambda and the lambda suture. It's a quadrilateral area. And on the two sides, there are two arbitrary lines over the parietal eminences. Now, what happens during the engagement? During the engagement, what happens? There are some diameters, anteroposterior diameter and the transverse diameter of the pelvis during the engagement, like that. So that is the pelvic girdle engagement. So in case of what anteroposterior diameter and what circumference will engage in the pelvis, that depends on the degree of flexion or extension. That is the attitude of the head. Attitude of the head. If there is a complete flexion, that is the suboccipitobregmatic, this is the suboccipito below the occiput, and it is the bregma. It is 9.5 centimeter. And then comes to the suboccipitofrontal, behind the same point below the occiput, and anteriorly it is on the forehead. It is on the forehead, and the anterior part of the bregma, And then the occipitofrontal, that is one from the occiput and the root of the nose. And it is actually 11.5 centimeter. Suboccipitofrontal is the 10 centimeter, it is 11.5 centimeter. And what occipitoposterior position happens in occipitoposterior, it is the occipitofrontal in deflexed attitude. It is the occipital deflexed attitude it engages. But it incomplete flexion, it will engage in the suboccipitofrontal. I am coming on to that. Next, another diameter, all of you know that maybe the early extension, that is the submentobregmatic. Submentobregmatic, this is the submentobregmatic, that is the anterofrontonally and the junction of the head and neck and the mandible, and then is the suboccipitobregmatic and suboccipitomental. There may be suboccipitomental incompletely extended faces, and there may be the mentovertical, that is the 14 centimeter mentovertical, the brow presentation. So this is the anteroposterior diameter. But what occurs in the vertex presentation, the diameter is the biparatal diameter, transverse diameter is the biparatal diameter. So with this introduction of the fetal skull and the pelvis, I am coming to the occipitoposterior portal. So what happens in the occipitoposterior? In occipitoposterior, this is the lie is longitudinal. This lie is longitudinal. Lie is longitudinal, and presentation is the vertex. Presentation is the vertex, and the engaging diameter, that is the engaging diameter. Diameter is occipitofrontal or suboccipitofrontal. I have said depending upon the degree of the deflection. This attitude is in deflection. Attitude is the deflection. And in case of, as I will describe now, the right occipitoposterior. In case of right occipitoposterior, occiput engages, the head engages in the right oblique diameter of the pelvis, which is 12 centimeter. This is the right sacroiliac joint, opposite is the iliopelvic eminence. This is 12 centimeter. It engages in the right oblique diameter. So what happened? It may be this is the delayed engagement. It may be the delayed engagement. That is the, so attitude, lie is longitudinal, attitude is in deflection, attitude is in deflection, engaging diameter is the occipitofrontal or suboccipitofrontal, and engages in the right oblique diameter, and the transverse diameter is the biparatal. So it is clear, I think. Now engagement occurs. After engagement, what happens after engagement? In majority of the cases, is the anterior rotation occur. And which cases the anterior rotation occur? It depends on the type of the pelvis. And another importance is the degree of flexion. That is how much it will flex. That is determined, as we know from the original idea. The flexion occurs due to the uterine contraction and also by the strength of levator muscle. And that to do, and by the strength of the levator muscle, as there is a poor, there will be less flexion. And if the good uterine contraction is poor, there will be less flexion. So if there is a good uterine contraction and levator muscle strong and the pelvis is adequate, we know in case occipitoposterior occurs in two types of pelvis mainly. One is the direct occipitoposterior may be occur in the anthropoid pelvis, that is the anteroposterior diameter more than the transverse diameter, and another is the android pelvis. And there is some problem in the android pelvis. So what will happen if in 90% cases, if there is a flexion, complete flexion, what will happen? It will deliver by the subocciput hinges and goes anteriorly and delivered by the normal lever. In the meantime, what will happen? As the shoulder cannot sustain too much of the rotation of the head, so there will be 2/8 anterior rotation of the shoulder. So 2/8 anterior rotation of the shoulder. And so 1/8 remaining. After delivery of the head, like the normal lever, after delivery of the head, there will be the restitution to untwist the shoulder, and then external rotation and the delivery occurs. So normal lever occurs after complete flexion, the 90 degree internal rotation, and the head is borne by extension, crowning, then head is borne by extension, crowning, and then restitution, and then external rotation. Now come to the what remaining 10%. The remaining 10%. The 10% is the fate depends upon the degree of the deflection. Degree of deflection. How much deflection? There may be mild deflection. There may be moderate deflection. There may be severe deflection. In case of mild deflection, what occurs? The occiput goes anteriorly, because the occiput touches the pelvic floor. Occiput touches the pelvic floor. So occiput goes anteriorly. But after that, there is no movement, there is no rotation. So what will happen? There will be the transverse arrest. That is called deep transverse arrest. What do you mean by deep transverse arrest? Deep transverse arrest, all the points are in the in this terminology. Deep means the head is in the deep. Transverse means the sagittal suture. Sagittal suture, that is the sagittal suture, lies transversely like this. Sagittal suture transversely like this, and there is no progress of lever after a significant period of time. Usually after the full dilatation. It is called full dilatation. So it is multigravida. It is more than half an hour, and it's called primigravida. It is hour. So this is the deep transverse arrest. So without aid or intervention, but delivery will not occur. Like the forceps rotation, manual rotation, forceps extraction, ventouse, or forceps rotation, forceps extraction. And if the pelvis is bad, then the cesarean section. So this is the fate of the deep transverse arrest. I will come later on during management. And next is if there is a moderate deflection, what will happen? Moderate deflection means the occiput and sinciput touches the pelvic floor in the same time. So no one can, either occiput or sinciput cannot go rotate anteriorly. So there will be arrest here. That is called the oblique posterior arrest. And this is same. This is actually the fate is same like the deep transverse arrest. But what happens another few cases? What happens if there is a severe deflection? In severe deflection, what will happen? The severe deflection, the sinciput touches the pelvic floor. As a law, which pole touches the pelvic floor, that will rotate anteriorly. So here, what will happen? The sinciput rotate anteriorly. And there is a malrotation of the occiput, and occiput lies along the sacral curvature, and sinciput go at the sinciput anteriorly to be delivered anteriorly. But not all the cases there is no delivery. So some of the cases there will be arrest, that is called direct occipitosacral arrest. But few of the cases where there is the pelvis is favorable, like the anthropoid pelvis or good cardiac pelvis, and average size baby is average size, and the good uterine contraction, the delivery may occur by the phase 2 pelvis delivery. That is called phase 2 pelvis delivery. What happens in this case? Phase 2 pelvis delivery. That is the you see the root of the nose. Root of the nose hinges under the symphysis pubis. Root of the nose, there is the stems under the symphysis pubis. And the head is delivered, that is from the brow, and then the vertex, and as the occiput is delivered. And this is followed by the delivery of the face by extension. Again, I am showing you what is happening in the face to pubis delivery. The root of the nose stems under the symphysis pubis. I can see everyone is able to see root of the nose stems under the symphysis pubis, and the head is delivered by flexion successively, first the brow, then the vertex, and followed by the occiput, and the face is delivered by extension. So what happens in this case? What happens in this case? The bipalatal diameter, they are usually lie in the posterior lineage, the rectum and the perineum. So as the larger bipedal bony diameter lies in the perineum, there is a more chance of complete perineal tear or oasis. Why oasis occur? Number one factor is the bipedal diameter stretches the perineum, because in normal liver, the bipedal diameter comes under the symphysis pubis, so there is no problem. But here is a chance of tear. And another important thing is that in diameter of emergence in case of occiputo posterior in the face to pubis delivery, diameter of its emergence is the occiputofrontal, that is the 11.5, so larger diameter. Diameter of emergence, that is the crowning occurs at this. So that is the second point where the complete perineal tear occurs. And third point, if it is the pelvis is not posteriorly not adequate, like the android pelvis, what will happen? There is a space behind lace, so there is a more chance of complete perineal tear. So prophylactically, you will have to give it is our indication, you will have to give the episiotomy, and you will maybe, if you are gentle to handle, so that there is a complete perineal tear now occur. So this is about the mechanism of the labor in case of occiputo-posterior face to pubis delivery. So in summarize, in 90% cases, 90% normal delivery about, but instead of prolonged labor, because why prolonged labor? Prolonged first stage of labor, prolonged second stage of labor. Why? Because the prolonged first stage of labor is due to the delayed engagement, and also the long internal rotation, and second page mainly by the internal rotation. So you will have to prepare that there will be the prolonged labor, the normal delivery also, and in that case also, as there is a prolonged labor, so forceps delivery you may require the forceps delivery, the prolonged labor. And the rest of the cases, 10% cases, some cases may arrest in the deep transverse position, and some cases oblique occiputo transverse position arrest, and some cases direct occiputo posterior arrest, and a few cases in favorable circumstances, there will be the face to pubis delivery. I have shown you the face to pubis delivery, and in face to pubis delivery, there is also prolonged labor. Either you can do normally, or usually the forceps you can give it, but the direction of the forceps something different from the normal occiputo anterior position. I will show you how will be the direction of the forceps during the management. If you know the mechanism of labor, so you will know or better understand how the direction of forceps occur. Now the management. So this is the fate. What will be the management when a patient you diagnose in the occiputo posterior position? So you take the proper history and proper general examination of the mother, and the stature, height, and also the BMI. You see general examination, pulse, BP, everything, other factors which may affect the obstetrics or the outcome of the obstetrics. And also you do the internal abdominal examination and internal examination to confirm the condition and what is in the stage of the labor. So you do examination. And next what will you do? You will do the patient, you do not allow so much of the mobility of the patient. Normally we do, because if there is a early rupture of membrane, in during pregnancy, or if it's the premature rupture of membrane also, rupture membrane, if the liquor is drained in the from the uterine cavity, so there is the delay, that will be the rotation will be hampered, because the back from the trunk needs also the trunk of the fetus also needs rotation, and if the liquor is less, so there will be no rotation of the trunk also. There will be the incomplete rotation. So that is the during the mobilization. And second is that what happened. Second is the what happened is the at the what happened actually, there will be the as the occiput posteriorly, there will be severe distressing pain near the occiput posteriorly. And two things. One is the distressing pain of the mother, because the occiput direct in the sacrum, the pressure over the nerves, and there is a severe distressing pain. So you will have to give the good analgesic during occipito-posterior position, good analgesic. And third is the what will happen other than the distressing pain, patient has usually sensation of the delivery. So give the premature bearing down pain, and patient will be tired and exhausted. You will have to counsel of the patient not to give the prior bearing down pain. So that is important. And as there is a cervix, the prolonged labor, why? One is the internal rotation long, and or the delayed engagement, and another thing is that as there is a less pressure over the fetal head over the uterus, there will be the premature rupture of membrane, and there will be the cervix will be edematous. Cervix will be edematous. So we will try so that there is no rupture of membrane early. That is not always in our hand, definitely, and there is a can be avoided. And next is about the channel management, that is the nutrition. What will you do about the nutrition? As there is a chance of interference in that case, even the cesarean section. So we will have to prepare, so the intravenous fluid we will better to give the method. And what about the bladder? There is a more chance of retention of urine. So we will have to catheterize and you will to evacuate whether at least when the patient can do herself, otherwise also the catheterize the bladder. And next, the main first stage of management, three management. One is the maternal monitoring. The monitoring three things. One is the maternal monitoring, and second is the fetal monitoring, and third is the progress of the labor monitoring. Maternal monitoring, you see the pulse, BP, and particularly the prolonged labor, particularly if there is a dehydration or not. The fluid giving is most important. Dehydration or not. Maternal monitoring. And better is to do should be routinely done the patograph. And then is the fetal monitoring. You give you see the fetal heart sound regularly, and also this is the case of the high risk case. So internatal CTG. You do the internatal CTG monitoring. And third is the progress. I will see the progress. Time to time you have to progress. Among the progress, that is the most important point, is the cervical dilation. You see whether the cervix is dilated properly in the patograph, and also the station is done by the abdominal method, the keystone method, the fifth method, or for only you can do the by the showing the ischial spine at the relation with the ischial spine, and also the flexion of the hand. Flexion of the head, how will be to do the sagittal suture. If the flexions occur, usually the anterior frontality is not palpable. And if it's an occipito-posterior, what happened? Both the anterior frontally and the posterior frontally is palpable. You see the sagittal suture, and the anterior frontally, you see the anterior frontally. In the anterior frontally, there is identified, there is a membrane and the fourth suture journey. and the posteriorly there is the triangular area, there is the lambdoid suture and 3 suture. And what happens in the normal lever, you will not be able to go to the reach the anterior fontanelle. But in case of occipito-posterior, you will able to touch both of them. And sometimes very difficult to palpate because of the less, because is the caput, more caput, is the more caput. So sometimes we will have to see the pinna which side, by palpating the pinna, which side is insipid, which side is. But if the progress is good, what will happen? Gradually the anterior fontanelle will not be palpable, the posterior fontanelle palpable. So you see the station, you see the rotation, and you can see also the flexion by palpation. And the station is the station and cervical dilatation of the. Regarding the molding, I am saying regarding the molding, in case of occipito anterior, molding occurs is actually more because that is the occipital bone goes beneath the this suture, and and also there is a molding of the sagittal suture. Molding occurs also to some extent the sagittal suture. But in case of occipito-posterior, the molding occurs. What is the molding? Molding means the shape is altered and the engaging diameter becomes less, made in the expression of the other diameter vertical to. What in case of occipito-posterior occur, the frontal bone actually goes beneath the parietal bone, and not so much of molding. That is the occipito-frontal diameter. Occipito-frontal diameter becomes lessened. That is the molding occur. So molding is not like that. Is the problem of the occipito-posterior. So these are the, now what will you do? The management of the cases, or other cases. So now come to the delivery of the if you see delivery of the face to pubis delivery. What happens? You see the face to pubis delivery. You see the face to pubis delivery. See the, so that is the in face to pubis delivery. Root of the nose hinges under the symphysis pubis. Head is delivered by flexion, the brow, the vertex, and the occiput, and rest is by the face is delivered by extension. So then what happens? Then restitution occurs and the restitution occurs, and then the external rotation occurs. But if there is a delay, what will you do other than and will episiotomy must give? And what will you do? The delay, you can give the forceps. How the forceps is given? How the forceps or the what will be the traction of the forceps? That is very important. You can know the mechanism. So suppose the root of the nose hinges under the symphysis. As the root of the nose stems under the symphysis pubis, so you will have to, during traction, you will have to give a traction horizontally backward, so that the root comes under the symphysis. That is the first reaction. That is the pull of the forceps. Then what will you do? Then you will deliver, as soon as the stems comes under the symphysis pubis, you deliver the forehead and then the vertex and the occiput. That will deliver the forceps. How will you give? You forceps, you will give upwards and forwards, So this is the second pull. And third pull is yet to deliver the fetal pecs. You will have to give the pull the downwards and backwards. That is the face is delivered. So there are three pull, the three different pull. One is the horizontally backward, and second is the forwards and upward, and then the face is delivered by down. So this is the pull of the forceps, and if you know the mechanism of the lever, it will be no problem. I think it is now clear. Now when the another conditions, or you'll have to do the interference like the arrest. What arrest may be? One is the deep transverse arrest. One is the deep transverse arrest. I have said that is the deep transverse arrest. And second is the deep oblique occipito-posterior arrest. And third is the direct occipito-sacral arrest. In three conditions it is called the persistent occipito-posterior position. Now, what will you do case of there is the arrest in the occipito-posterior position? We know to assess the pelvis, and if it's not vaginal delivery is not present, so better is to do the cesarean section. Better is to do the go to the cesarean section. You see, assess everything, the fetus height, uterine contraction, and also the pelvis. And another one important thing is that in the first stage of labor, always you give the oxytocin, because less uterine contraction and uterine tonicity is sort of the important factor of occipito-posterior and for incomplete flexion. So you must give the oxytocin. And in the meantime, you counsel the patient, and that there will be maybe delayed, and also the patient party also. They are worried, but there may be delayed. Don't be worried. Whatever he will be done, you can go there. So if you think there is no chance of vaginal delivery, you directly go to the cesarean section. But what are the other method? Other method is that there is the first method is the manual rotation, modal rotation, and forceps extraction. Very experienced obstetrician is needed. Forceps extraction. Second is the forceps rotation and the forceps extraction. Why like the Killian forceps? We are not accustomed, but in some country it is done. Some country it is done with the Killian forceps. And third is the ventrus. So I will show you how the manual rotation is done. Manual rotation and forceps extraction is done. You see, the manual rotation, suppose the deep transverse arrest is like this. What will you do? That can be done Hoppen method and also the full hand method. Hoppen method and the full hand method. You can see the Hoppen method, there is the only right hand is used in the Hoppen method. And full hand method, both the hands are used. But before that, one thing you remember, if there is no good flexion of the head, it will be very difficult. So what will you try? You try to flex the head from below, giving pressure more above the forehead, and the assistant you will give the pressure over the fundus, so that the dislodgement doesn't occur. So the flexion you try to do is flexion. Then what will you do? Then we will do the Hoppen method. Only the right hand is used. Suppose there is a occipito-transverse position, right occipito-transverse position. You will do the four fingers anteriorly, and will rotate like this. Four finger anteriorly and rotate like. If you the dummy pitas, you see the four finger anteriorly, and you rotate. And my left hand, what to do my left hand? My left hand also rotate abdominally, my left hand also rotate the shoulder on that side. Then keeping the fingers under the finger on the left side, you push the forceps blade, left blade first, followed by the right blade, and delivery occurs by the long forceps you will take. Definitely the long curve obstetric forceps is good. But if it is the right, like this, is the right, the left, what will happen? You rotate the hands like this, the same hand rotates like this, and then you apply the forceps and deliver the head. And it's actually the Hoppen method. But full hand method, both hand you can use. You also introduce the thumb also, full hand method. But the right occipito anterior is like the full hand method. It's like this, and tangential manner, you will give the pressure. And also, if there is a, if there is a, if there is a left occipital transverse, you also rotate like this, and then you also perceive. So what happens in case of right occipito-posterior? If it is the right occipito-posterior, you will have to put the right blade first. You will have to put the right blade first, and the left blade from the billward. That according to the. So this is the method of the delivery of the head in the forceps rotation, the manual rotation and forceps rotation, and it should always be done by an experienced obstetrician and under anesthesia. And other is the ventus, like the you can do the ventus. You can do the ventus. Ventus, you will use the flexion point. You will give the flexion point. But if there is a contraction of the pelvic contraction, then what will happen? There is a chance of failure in the ventus. And Killian forceps, I am not going into if there is a forceps class, I will do the Killian forceps. There are the three methods of the delivery by the Killian forceps. So these are about the delivery of the arrest condition, deep transverse arrest, so right oblique posterior arrest. And really it is difficult is where there is actually the direct occipito-posterior arrest. This is only direct occipito-posterior arrest is only the in case of arrest only 1% cases. But that is very difficult to rotate all the things. Difficult to rotate the head and put the forceps. So again, I will stress on the thing. In case of which pelvis actually, that is the anthropoid pelvis, a more chance of occipito-posterior, but there is the face-to-pelvis delivery, the chance of complete perineal less. If it is the android pelvis, there is a complete perineal tear is more, and there is a more chance of the cesarean section. And as the uterine contraction, poor uterine contraction is one of the important, poor uterine contraction is one of the factor. So there you will have to give the oxytocin, and in multicavida particularly, as the lax abdomen and poor liver tonitis, occipito-posterior is more. And there is some causes of occipito-posterior with the fetus itself is like the deflexed head, large baby, brachycephalic baby. And another important thing is the PRO. So this is all about the occipito-posterior. So now the summarize of the whole things of the occipito-posterior. In case of 90% cases, in occipito-posterior, the normal vaginal delivery occur, but at the expense of the prolonged labor. That is important. And in case of 10% cases, and the fate depends on the degree of the deflection. If there is a mild deflection, and what will happen, there will be the go to the anteriorly 1/8, and there will be the head and the occiput and sicciput try to touch the pelvic floor. For the same time, there will be the deep transverse arrest. If there is a moderate deflection, the occiput and sicciput lies in the same plane at the oblique diameter, and both tries to come anteriorly. So there will be arrest in case of in this oblique diameter. And rest of the cases, there will be the instead of occiput, sinciput forwards due to the severe deflection, and occiput rotates posteriorly to come to the sacral curvature. And this is the partial direct occipito-sacral position. But in some few cases of them, if the condition is favorable, there is a chance of face-to-pelvis. There is a chance of face-to-pelvis delivery. There is a face-to-pelvis delivery, either normal or you can give the forceps I have shown. So reaction is also shown. And if there is a deep arrest, you assess the pelvis, and also the maternal condition, other obstetrical factor and medical factor, you judge the case and you will directly go to the cesarean section, or you can do the manual rotation and the forceps extraction, or the forceps extraction and forceps traction with the forceps rotation and traction with the heel and forceps. And third is the auto rotation and extraction by the ventrus. So this is all about. So this is about the fate of the occipital posterior, and there will be the prolonged labor. There will be the prolonged labor region. One is the first is the delayed engagement, long internal rotation, and also the pressure over the cervix is less, and so there will be the delayed progress of the cervical dilation. Cervix may be edematous, and if there is chance of premature rupture of the cord, there may be also the cord, but there will be prolonged labor. So you will have to give the oxytocin. So these and always there is a complete perineal tear. You remember about the complete perineal tear. Oasis in case of post-pubis delivery, if ever. The most important thing is that you counsel the patient and you say the patient, I am with you, and also the patient party, that may be the fate, and time to time they will have to put up. So thank you for giving me this opportunity, Dr. Ashok Kumar, Dr. Ashish, Dr. Porag, and Dr. Hafizur, and all the dignitaries and the office bearers of the FOGSI and ICOG. So thank you, Hafizur, Dr. Ashish, and coordinator, and also Dr. Porag and Dr. Ashok Kumar for conducting really the 4 years. This tutorial is a very difficult in every month, one Sunday. Thank you all.
Thank you so much, Mazi sir. That was an exceptional demonstration on behalf of on part of you, and I am sure the students will be immensely benefited with all of your expertise as well as practical demonstration. And I would like to remind the students that these presentations will be in the record of the ICOG website. So those who have missed, or those who wants to have repeatedly have skill enhance on this, they can later on go to the website and access it. So this also shows, Mazi sir, you're passionate for teaching the students, and it has been phenomenal to have been with the teaching the students so much. So thank you so much, Mazi sir, from the ICOG, and we are fortunate to have you, and we would like to have in your future sessions, because the students would like to or love to hear you or see your demonstration. So thank you so much, sir. So would like to request you, if you can stay, then it will be nice, because the students will be presenting the case for the case on endometrial cancer. Thank you so much, sir. So now we will have, now we'll move on to the second session, that is the case discussion. So the students, Dr. Radha Gupta and Dr. Srikant Dadich, they are students from Gujarat Cancer and Research Institute. They will be presenting a case on endometrial cancer. And we have very galaxy of faculties and their experienced one. Dr. Ashish is there, he might join a little later. Then we have very experienced Professor Amita Suneja Madam. Madam is former principal and HUD OBGYN and GTB, UCMS and GTB Hospital, Delhi. Then we have experienced very much senior professor, Professor Dr. Sunesh Kumar. Sir is former professor and HOD at AIIMS, New Delhi. Then we have Madam Dr. Bhagyalasmi Nayak. Madam is professor at Acharya Harihar Postgraduate Institute of Cancer at Cuttack, Odisha. And then we have Dr. Deepanita. She is associate professor at Chittananda National Cancer Institute, Kolkata. So I'd like to request Dr. Radha Gupta and Dr. Srikant to share your presentation, introduce yourself and start presenting. And at the same time, I'd like to request our esteemed faculties, Madam Dr. Amita Suneja Madam, Dr. Sunesh Kumar, Dr. Bhagyalasmi Nayak Madam, and Dr. Deepanita Banerjee to take over, please, and have the students. So I'd like to say that the Dr. Radha and Dr. Srikant are MC's students of the GCRI, that Gujarat Cancer Research Institute in Gynec Oncology. So over to the faculties, all of you, please.
Thank you.
Thank you. Thank you.
Thank you.
We can start with the presentation. It has been under the guidance of Dr. Bejal Patel, and both Dr. Radha and Dr. Shrikant are requested to start with the presentation. Once you present, then we have number of questions put to both of you.
Yes, sir.
Good afternoon, everyone. Myself, Dr. Radha, and my colleague, Dr. Shrikant, we are going to do today's case presentation under the guidance of
Radha,
Dr.
please
Bijal Manish
switch on
Patel.
your video. Can you switch?
Yes, sir.
Shrikant, are you there?
Yes, sir.
Sir, I'm not able to do it from my side. Can you do it? sir?
Okay.
Hello,
Have
ma'am.
you joined from the technical team? Can you help?
Yes, yes,
Have you
yes.
joined from?
Ma'am, I'm sending one request to you. Can you please allow that request?
Yes.
Okay. Now you're audible.
Please.
Yes, visible, ma'am, visible.
No, it's again gone, no?
Visible, sir.
No, she's visible.
Okay, okay. So please keep on your video on always during the presentation as well as during the crossing. Please, please continue. Please go ahead.
So we are going to do today's case presentation under the guidance of Dr. Bijal Manish Patel, ma'am. My patient is a 57 years old female. She is a resident of Ahmedabad, Gujarat. She is educated up to 10th standard and she is homemaker by occupation. And she belongs to lower middle class by modified Kupuswamy classification.
Yes, yes, sir. Perfectly audible.
She presented to us with chief complaint of postmenopausal bleeding for 2 months. Patient was apparently well 2 months back when she noticed bleeding per vaginum, for which she uses 1 to 2 pads per day. Bleeding is scanty in amount with no aggravating factor. There is no history of passage of clots per vaginum. This bleeding was not associated with any discharge PV. There was no history of abdominal pain, fever, or lower backache. There was no history of increased urinary frequency, burning micturition, or blood in urine. And similarly, there was no history of constipation or blood in stool. There was no history of lump per abdomen or mass descending per vaginum. It was not associated with loss of appetite or loss of weight. There was no history of fatigue or palpitation. There was no history of cough, breathlessness, headache, or seizure. For her presenting complaint, she got herself evaluated at a private hospital where she underwent dilatation and curettage. She was informed that report is suggestive of malignancy and she was referred to our institute for further management. Menstrual history. She attained menarche at the age of 13 years. Her prior menstrual cycles, they were regular. She attained menopause 4 years back at the age of 53 years. Perimenopausal period was uneventful and there was no history of HRT intake. Obstetric history. She got married at the age of 20 years. She had para 2, live 2, both were full-term normal vaginal delivery. Her age at first childbirth was 23 years and age at last childbirth was 33 years back. And tubal ligation was done. Past history. She is a known case of hypertension for 5 years. She is on oral antihypertensive. There is no history of diabetes, mellitus, stroke, TB, HIV, or any hospitalization. No history of any other medication intake beside the antihypertensive. There is no history of COVID vaccine intake. There is no history of any surgery except tubal ligation. Family history. There is no history
So,
of.
Radha,
Yes, ma'am.
did you take any history of hormone replacement therapy?
Yes, she has
ma'am.
told. Deepanavati, she has told already.
Is she okay? Okay.
Yes, ma'am. Family history. There is no history of cancer in family member on both maternal and paternal side. Personal history. She is a vegetarian by diet. Her appetite is normal. Bowel and bladder habit are regular. Sleep is adequate. There is no history of smoking, alcohol intake, or tobacco chewing. There is no history of prior cervical cancer screening. There is no history of high-risk sexual behavior in self or partner. Dietary history, her total calorie intake is 2200 kilocalorie per day. Total calorie requirement as per ICMR is 2024 kilocalorie per day. Her total protein intake per day is 30 gram. Total protein requirement is 36.3 gram per day. So excess calorie is 176 kilocalorie per day and protein deficit is 6.3 gram per day. General examination, sir will take over.
I think before Shrikant tells, Sunesh sir, any comments sir from you?
I just thought let them present,
Okay,
and
sir.
then we'll start putting question and
Okay,
in
sir.
alphabetical order.
Okay, perfect.
First Dr. Amita, then Dr. Bhagya, then Dr. Dipanvita, and if time permits, last I will put question.
No, sir, in order of seniority, I will tell.
Acha, okay.
Yes,
Shall I continue, sir?
please.
Yes.
So coming to general examination, patient is conscious, cooperative, oriented to time, place, person. ECOG performance score 0, moderately built and nourished. Pulse 80 beats per minute, regular, normovolumic. Blood pressure 128 by 80 millimeter of mercury, taken on right arm on sitting position. Respiratory rate 18 per minute. SpO2 98% on room air. Temperature 98.2 Fahrenheit. Height 170 centimeters, weight 70 kilograms, making BMI 24.2 kilogram per meter square, overweight as per Asian standards. Pallor icterus, cyanosis, clubbing edema all absent, lymphadenopathy absent, neck no thyroid swelling, breast and axilla normal. Coming to systemic examination, respiratory system, bilateral normal vesicular breath sounds heard, no added sounds. Cardiovascular system, S1, S2 heard, no murmurs. Nervous system, normal. Coming to per abdomen examination on inspection, abdomen normal in shape, all quadrants equally moving with respiration, no discoloration seen. Umbilicus normal, no visible pulsations or dilated veins, no cough impulse. 2 centimeter scar of tubal ligation below the umbilicus present. No other scars or lesions on abdomen, all hernial orifices checked. Palpation, soft, non-distended abdomen, non-tender, no local rise in temperature, no organomegaly or palpable mass. On percussion, no demonstrable free fluid, liver not enlarged. On auscultation, normal bowel sounds heard. On gynecological examination, vulva normal externally, no lesion or any hypopigmentation. On perspeculum examination, cervix and vagina healthy, no erosion or growth. LBC with HPV taken at the time of examination. On per vaginum examination, cervix firm, uterus 8-week size on bimanual examination and retroverted. Antero-posterior uterine mobility was restricted. All fornices were free. On PR examination, POD smooth, bilateral parametria free, rectal mucosa free. To summarize the case, my patient, 57 years old, para 2 living 2, post-menopausal lady with PMB under evaluation with outside DNC suggestive of malignancy with normal findings on per speculum examination with bulky uterus on PV examination.
Thank you. Any question to presenters at this stage?
Can I say there's one very well presented, but there's one conceptual mistake in this. Radhika said her protein intake is 30 gram per day, which is, and RDA says 30.6 gram. It's grossly inadequate. For women, it is on an average 1 gram per day, and for women, you can take 0.8 gram per day, and she's 70 kg. So at least she should be having 56 grams of protein.
Thank
She
you,
has
Dr.
told that it is deficient, but
No,
I
she
think the
said
numbers.
only 30 and 30.6 she mentioned.
Hmm.
Radhika, or is just the error in typing?
And Dr. Dipanvita, any questions?
The spelling mistakes, there are a few spelling mistakes. Calorie spelling is different.
Yes.
RIE should be there. There's typo
Yeah.
error, man. RIE should be there.
Agreed.
Radha, what is your provisional diagnosis?
Ma'am, my provisional diagnosis according to the history, she's a 57-year-old postmenopausal with postmenopausal bleeding, which is scanty in amount. But as the patient presented with the report of malignancy, the following outside DNC was done. So my first DD will be endometrial carcinoma.
No, you will always not get the malignancy report. The patient presents with postmenopausal bleeding. What will be your first provisional diagnosis based on the history?
Okay, ma'am. Then my first differential diagnosis will be atopic endometritis or vaginitis because that is the most common cause of postmenopausal bleeding. And
Yeah, so
yes, ma'am.
And what will be the
You-
first investigation if she has come without a biopsy report in such a patient? What will be the first investigation that you will like to carry out?
My first investigation, sir, will be transvaginal ultrasound.
Correct.
Can I add, like her uterus size is it's bulky, I think.
Yes, ma'am.
So in atrophic, it won't be bulky. We at this age, we have to keep endometrial CA as the first diagnosis.
Yes, ma'am. If we include the
Oh, ma'am.
examination finding also, then my differential
Okay.
diagnosis will be endometrial carcinoma or
History.
endometrial polyp. It can be.
Okay.
Radha, what was her BMI?
24, ma'am. 24.
24.
Yes.
Okay.
Any
So
risk factor you can identify in this patient from history?
Any risk factors, ma'am?
Yeah, for endometrial CA. Can
Yes,
you
ma'am.
point out the
Yes.
risk?
Yes, ma'am. Ma'am, patients delayed menopause, 53 years as per
Maybe.
Indian standards, and
Yeah.
BMI, she is in overweight category.
Yeah, not
Yeah, but no, not that, but
obese.
borderline.
Yeah.
Yes, ma'am. As per Asian standards, ma'am. And
And
That's-
otherwise, no other risk. Early menarche, 12 years, they say, but she had 13.
13 years.
Yes.
Okay.
So
Yeah, and
here
yes, yes, sir.
here we had a patient where diagnosis was there by the time she reached us in the hospital. Now, next thing is how to proceed further. Dr. Radha first and then Dr. Shrikant.
Yes, sir. Sir, after we have done the TVS, then we will proceed with the endocervical curettage and endometrial biopsy, sir.
Radha, just a minute. So your next will depend on your ultrasound findings, right?
Yes,
It's
ma'am.
not that I do a TVS and then go ahead with a endocervical curettage and this and that. Okay.
Yes.
So so what findings do you expect on TV scan?
TVS,
What-
ma'am.
Yes.
To describe the finding of the endometrium in TVS, there is ITA guideline, International Endometrial Tumor Analysis, according to which 7 parameters are there, according to which we should describe the endometrial finding. If the tumor is present, then the dimension of the tumor, and the second is tumor ecogenicity, and third, if there is no tumor, then the endometrial lining. How is the endometrial lining? 4 is the intracavitary collection, if it is there. 5 is tumor vascularity, and 6 is tumor vascularity and to endomyometrial junction. How it is the endomyometrial junction, and 7 is the color score. According to this, we should describe the finding of the TVS, and if we find any lesion in the endometrium or hyperplasia, then we should proceed with the endometrial biopsy.
And what else should you look at when you're doing a TV scan?
TVS, then I should look for the adnexa also, and I should look if there is involvement of if the tumor is large and there is it is extending to the cervix. If there is involvement of the vagina or parametria, we can also see this in the TVS.
Yeah,
And
suppose
Dr.
it's just
Shrikant, sorry.
yes.
And Dr. Shrikant,
Yes, sir.
which is the best way of knowing whether the cervix is involved or no?
Sir, MRI.
What are the other ways by which you try to find out involvement of cervix?
Sir, on clinical examination also, if cervix is bulky, we can have suspicion of involvement of cervix. So in this case, it wasn't bulky. This was the first thing on clinical. Then, sir, on TVS also we can see there is cervical stromal invasion is there. Tumor is going or not. Then MRI. Then after biopsy report also by IHC markers also we can see, sir. P16 positive is seen in cervical involvement.
What
So
about
will you see cervix bulky, or will you get some growth on cervix on speculum examination?
Sir, ma'am, if it's coming from endometrium, so it can be bulky or ballooned cervix, ma'am. It can be.
So it can be ballooned in mostly in the endocervical.
Endocervical.
It
Yes,
can be endometrial or endocervical.
cervical. Yes, ma'am.
any
So,
role of
but if there's
hysteroscopy?
Any other test by which we can know whether endocervix is involved?
Endocervical curettage we can do.
What about hysteroscopy?
That curettage sometimes picks up cell which have shed from the body of uterus. What about hysteroscopy? And while doing hysteroscopy, see endocervical canal.
Sir, yes, sir.
And out of these 5 tests, which is the best?
Hysteroscopy, ma'am. Sir, hysteroscopy. Mhm.
And if not MRI?
MRI, sir, if when it comes to non-invasive thing, then definitely MRI is better, sir.
MRI will give you a lot of other information.
Yes, sir. Myometrial invasion also, even adnexal involvement, pelvic nodes also can be seen,
Yes.
parametrial involvement. Yes, sir.
Because with hysteroscopy, there is little apprehension that fluid which we are using may result in spillage of malignant cell into the peritoneum.
Yes, sir. But now they say, sir, that in hysteroscopy, if spillage is there, prognosis is not altered, because if serosal breach or ovarian involvement is there, and then if peritoneal fluid for cyto is positive, then impact on prognosis will be there. But now, sir, I think that hysteroscopic fluid will not alter.
Doesn't alter the prognosis.
Yes, yes, sir.
Dr. Radha,
Yes, sir.
so having taken history, having examined her, and knowing her histopath, what is your clinical staging? Although in C endometrium it is pathological staging, but still, what is your clinical staging?
Sir, my clinical staging will be stage 1. According to the clinical examination, it will be stage 1.
Or
it can be 2 if cervical stroma is involved.
yes.
And since you already have the histopathology, when will you plan for IHC for molecular markers?
Ma'am, when biopsy is taken on biopsy tissue only, it should be done, because if disease is confined, there is minimal invasion and we've taken the biopsy. So there is possibility that larger part of the tumor tissue has been taken off in the DNC itself. So on that, if we put for IHC markers, 2 things will be there. Proper tissue amount will be there in tumor tissue will be there. Other pre-operatively or before the management, we will have some idea if it is P53 mutant, or it may guide us for.
How does IHC helps us in clinical management of the patient? Like histopathology, you haven't gone to the histopathology yet, but suppose her histopathology shows adenoCA, endometrium.
Yes,
so in that case, or any endometrial cancer where preoperative IHC, how does it alter the management? Surgical management.
Surgical management, yes, ma'am. Ma'am, in IHC, if it is serous or carcinosarcoma, then infracolic omentectomy is done in that case.
Second, that is histopathology, that is not IHC.
IHC.
In histopathology only we will know whether it's serous or IHC. Madam is asking about
yes,
IHC.
ma'am. Yes. Ma'am, if P53 mutant, then it is it may guide us that to prognosticate. So we can go for infracolic omentectomy, though it is not indicated based on P53 mutant, but we can go for it if mutant is there.
Dr. Radha, can you now quickly present her investigation reports?
Yes, sir. Her LBC was atypical glandular cell, HPV negative, ECC negative for dysplasia or malignancy, endometrial biopsy, adenocarcinoma, IC given. So IC was ER positive, Vimentin positive, P16 block positive, P53 null type, CEA negative, WT negative. So the diagnosis was endometrioid adenocarcinoma, FIGO grade 3.
Okay.
These are the blood investigations. They were within normal limit.
Unit plan, yeah.
This is the TBS, presence of 62 into 43 into 45 ill-defined heterogeneous lesion involving endometrial cavity, and there is more than 50% myometrial invasion in posterior wall. Cervix bulky, measure 26 into 35 Then we got the chest X-ray and bilateral mammography done. This is the CT. 47 into 49 into 48 size, enhancing soft tissue density lesion is noted involving fundus of uterus, lesion indent posterior wall of urinary bladder, and reaches up to upper part of the cervix. And lymph node, they were only subcentimetric. So comment report was heterogeneously enhancing soft tissue density lesion involving fundus of uterus with extension and involvement, and malignant mass lesion appeared likely.
Thank you. So after getting investigation reports, what was your staging? Although it is going to be final at surgery.
1B, sir.
You are following which stage? 2023 or 2019?
2C.
If 2023, then 2C, ma'am.
2C.
But if old staging, then 1B.
Will be 1.
So why 2C?
Why 2C? Yeah.
Endometrioid grade 3 aggressive histology with myometrial invasion, ma'am. With any myometrial invasion in aggressive histology is 2C.
So then in that brings a question, which one are non-aggressive and which all are aggressive histology?
Non-aggressive is endometrioid grade 1 and 2, and aggressive histology is endometrioid grade 3, serous, clear cell carcinosarcoma, and differentiated and mixed.
Why did
So
we do, sorry.
Yes, sir. Please. No, sir, please.
And why did we do CA125 level in this patient?
Sir, it is recommended to do CA125 just because it may tell us about any serosal spread or peritoneal involvement. So,
Peritoneal disease.
yes.
So
And
in
I
a
want-
CA endometrial.
Can I interrupt, sir?
Sorry.
Can you give molecular staging that you did not add in it?
Because you have done all the molecular markers, right?
Yeah.
So I think you can apparently give us a molecular stage, though we don't have the surgery.
Pole E not done, ma'am.
It doesn't matter, but P53
That's fine.
is
Pole
positive.
is not mandatory always.
Yeah, and P53 null type means it is positive, isn't it?
Yes, yes.
So she becomes
High risk.
High risk. What stage?
2C.
Raised CA125 level indicates extra uterine spread of the disease.
Yes, sir. Yes, sir.
Is there any place of doing PET scan in this patient before proceeding with surgery?
Yes, sir. If we are suspecting the distant mets which cannot be seen in the CT scan, then we can go ahead with the PET CT. For lymph node also, the PET CT has more specificity than the CT.
I think patient who have type 2 disease, papillary serous variety, clear cell variety, CA125 levels are high, then one can go for PET scan, but not as a routine.
Yes.
Yes, sir.
Radha, I have a little query, sir. Sir, because she has P53 null type and a P16 is block positive. And but the histopathology is still endometrioid adenocarcinoma grade 3.
Yes.
So how can we explain this? Because P16 is usually not positive in endometrioid adenocarcinoma and we have a block positivity here.
Yes,
And
serious
we
towards
agree
serious.
with you, and I'm not expert in that. We need to take help of pathologists.
Dr. Patel will explain later, but
Yes.
doesn't go hand in hand.
Yes.
We can have the final report then. So what surgery was done and
So now at the end of history
Surgery
examination and investigation, here is a patient who has adenocarcinoma, poorly differentiated to grade 3. And according to latest FIGO staging, she is stage 2C. So what is the plan of treatment?
Sir, in this case, we can offer sentinel lymph node also to the patient, but we
We'll ask you later. First, what procedure was done?
Okay, we did total abdominal hysterectomy, bilateral salpingo-oophorectomy, bilateral pelvic lymph node dissection, para-aortic lymph node sampling, infracolic omentectomy, and multiple random peritoneal biopsies and peritoneal fluid for cytology.
So the first line of treatment is surgery.
Yes, sir.
Although she's 2C, even if she was stage 3 in carcinoma endometrium, surgery is the first line of treatment. And only exception is she has a stage 4 disease or she is not fit for surgery, then we may omit, otherwise surgery.
Yes.
And as Dr. Shrikant highlighted, during surgery, he would like to remove these things. So now, Dr. Radha,
Yes.
although we keep doing surgery for so many malignancies, what are the steps of surgery in carcinoma endometrium and how it is different from a benign surgery for benign disease?
Yes.
Sir. So in CA endometrium, sir, at our institute, we are doing open surgery. We are not doing minimally invasive surgery now. So first we will take the consent of the patient and we will explain all the all the benefit and all the adverse effect of the surgery. And then we will proceed. After anesthesia, first we will give prophylactic antibiotic. And then we give midline vertical incision. In benign cases, you can give a transverse incision also. But in carcinoma cases, as we want to do para-aortic lymph node dissection also, we give midline vertical incision.
Dr. Radha, I'll just interrupt here. So
Yes.
in all cases, you want to do a vertical midline incision?
Ma'am, where we want
why?
to do para-aortic
And why?
lymph node dissection also.
Sorry?
Ma'am, where we want to proceed with the para-aortic lymph node sampling, there will be.
So then the next question is where you will do para-aortic.
Yes,
Do you do para-aortic in all cases of endometrial cancer, or you are selective that these are the cases we'll do para-aortic and few of the cases we will be happy with doing only a pelvic lymph node?
And patient is
Ma'am,
morbidly obese sometimes.
Yes, ma'am.
Most authorities recommend that while doing surgery for C endometrium, a vertical incision is preferable. So first is vertical incision. Next
Yes, sir.
step.
Sir, we'll just look at if it is a very obese patient and we are sure that we will be stopping with pelvic only, then transverse incision will be good, because many times they're so obese, it becomes really the wound healing and all those things become a little problematic. Dr. Dipanvita, your opinion?
Agreed with Dr. Bhatia.
Yes, sir.
Yes, Dr. Bhagia, we also prefer to do transverse muscle cutting incision when patient is morbidly obese.
Yeah.
And when our plan is not to do para-aortic or
Para-aortic, yes.
mental.
And the message should be that, of course, first choice will be robotic, depending upon your facilities available. If it is open, then it can be opened by transverse if we are not doing para-aortic.
Ma'am, in
No,
this,
but in this histology, you will do
Do
or you
para-
will not?
yes, ma'am, here
We
we
will do para-aortic lymph node sampling.
Yeah, with this, we have to do omentectomy also. So we'll
Yes,
go
ma'am.
open by vertical, then out.
After
Yeah,
opening
please
the
go ahead.
abdomen,
Yes. Let's go to the steps. Okay,
Yeah.
so vertical midline, all of us agree. Then what?
Okay, after
Next
the
step.
incision, we will take the if ascites is not present, we will take peritoneal wash for cytology, and then we will explore the abdomen. If any extrauterine disease is present, we should systematically we will explore the abdomen like cecum, appendix, small.
So clockwise, you have done that. Next.
I think there is some problem.
I also facing problem. I thought it's with me.
So
No, I
after
think
taking
Dr. Radha
cytology,
has lost
You can,
connection.
you keep speaking, Radhika.
go
Prashant can answer.
Yes, ma'am. Peritoneal wash will give and will
Shrikant, sorry,
Ji. Yes, ma'am. It's okay, ma'am. So already we've done abdominal inspection and cytology has been taken. Then every step, ma'am, I should tell in detail.
Yeah,
Just-
what's the difference between benign and this?
Okay.
Highlight the salient features.
Ji. Ji, ma'am. After that, we will inspect ovaries also, whether there is any involvement. Uterus, we'll see if there is any serosal breach is there on gross. And all the all the spaces we will open, ma'am. All the spaces, paravesical, pararectal. And we'll look for any enlarged lymph nodes also at the same time. And here, while doing oophorectomy, IP ligament will ligate 2 centimeter proximal to the tubal end. And then we'll proceed for hysterectomy, ma'am.
Any other
Type of hysterectomy? What's the type of hysterectomy?
Ma'am, extrafacial type 1. Here we are doing extrafacial only, type 1 only, ma'am.
How did you open the vagina?
Vagina, okay, ma'am. Means when I reach the vault, then I will open. Okay, ma'am. Okay, ma'am,
We'll open
I'll
it from lateral angle, some from the center. Which is preferred? And
The
why?
only thing is round ligament should be clamped, ligated as
yes,
little as possible.
Yes,
And
yes,
this-
sir. As
In
lateral as
exam,
possible.
these are the frequently asked questions.
Sir.
And you don't roll over the clamps over the cervix.
Yes,
So
yes, ma'am.
And they often ask while doing surgery,
We will.
what steps will be taken to prevent spillage of malignant cells.
Yes, sir. Yes, sir. And minimal handling of the uterus. There can be crushing of the tumor also. So while delivering the specimen, it can spill out in the abdominal cavity as well. So we'll be careful with that also, with minimal handling, because
don't cut
that is
the vagina jutting with the cervix. So
Yes,
better
sir.
open
Yes,
the
ma'am.
wall from center.
Yes, ma'am. Stab incision will give in the center, and then we'll start
Mostly the commonest site of recurrence is vault of the
Vault
vagina.
rectus. Yes, sir.
So people take extra steps to prevent spillage of malignant cell when you reach that level cervix. Some people will put 2 parallel clamps and cut in between so that malignant cells don't spill in the vagina.
Sir, yes, sir.
And ligation, she's tubal ligated. So otherwise it's preferable, though it's not mentioned, to put the clamps on the tubal end first so that there's no spill of the cells in the cavity. But
Yes, sir. Yes, ma'am.
books don't mention this.
Yes, ma'am.
But madam, whenever we are doing at least a lap surgery, that's the first step.
That's the first step. Yes.
Yeah.
And once specimen is out, what are you going to do?
Sir, we'll give the wash at before closure of the vault. We'll pour some saline and we'll clean it. Then with betadine also we do practice here to clean that.
More important is your assistants who are there in the OT, ask them to cut open the specimen and
Yes,
show
sir.
the.
Yes, sir. Yes, sir.
Should
How
you
is that?
send it, should you send it for frozen or not?
No, ma'am. Now this practice is not there anymore. But previously, there used to be this practice to send it for frozen myometrial invasion. They used to tell, and accordingly, pelvic lymphadenectomy call was taken based on the invasion part. But now this practice is
So
not
is
being
there
done.
any indication of doing frozen section in endometrial CA?
At
Is there
present,
any
ma'am,
indication of doing frozen section in endometrial CA?
now if we have pre-op diagnosis, then we are not doing it. If we have pre-op IHC
it
diagnosis,
is
we are not doing.
not indicated.
Yes,
There's no
ma'am. not
indication at
indicated.
present.
Yes, ma'am. Yes, ma'am.
No indication, no recommendation.
Yes, ma'am. Yes, ma'am.
That is important.
Yes, ma'am. Previously, before the Sentinel era, that used to be the practice of Mayo's criteria. They used to do.
Another disadvantage of frozen is that it changes the architecture. So later on,
Yes.
immunohistochemistry, it is difficult to do the molecular testing.
Yes, ma'am.
Do all patients who are being operated require lymphadenectomy?
Sir, lymphadenectomy, in this particular case, it was required, sir. Though there is no therapeutic role, but since it is surgical staging,
So,
surgico-pathological.
please understand what sir is telling. He is
Yes, ma'am.
asking, do all patients of endometrial cancer need lymphadenectomy? On the other hand, what are the indications of lymphadenectomy in endometrial cancer?
Okay, ma'am. Ma'am, if there is grade 1, grade 1 less than 50% myometrial invasion, then But ma'am, now we are doing, ma'am, sentinel lymph node mapping is done in all the
What is
patients.
Mayo criteria, Shikant?
Mayo criteria, ma'am, if tumor size is less than 2 centimeter, if it is grade 1 and myometrial invasion is less than 50%, then lymphadenectomy can be omitted. But
And tumor size?
less than 2 centimeter, ma'am.
Yes.
There is, but now, ma'am, this practice is not being done anymore
Yeah,
because
when you
sentinel.
have IHC and all those things in hand,
Yes,
I
ma'am.
think.
Yes, ma'am. And
Yeah.
sentinel should be used, ma'am. Sentinel should be promoted to use. So there we can omit the systematic lymphadenectomy
How
by
do
doing
we,
sentinel.
sorry, how do we do sentinel lymph node sampling in the case of C endometrium?
Yes, sir. Sir, we can use dual dye in the form of technetium 99 and methylene blue, or we can use ICG dye as well, depending upon the availability and the practice in the institute. We are using at present ICG also, sir, along with TC99.
In open surgery,
In yes, open surgery TC99 and methylene blue we are using.
where will you inject the dye?
Yes, sir. Sir, cervical injection should be given. If we are using technetium 99, then at the 4 positions we will inject the dye a day prior to the surgery. Sir, 2 o'clock, 4 o'clock, and 8 o'clock and 10 o'clock. Superficial and deep, 1 to 3 mm superficial and 1 to 2 centimeter deep. Deep to cover the periaortic part. And in the OT, before starting the surgery, we will inject methylene blue dye at the 3 o'clock position and 9 o'clock position. Whereas ICG, we do inject only at 3 o'clock and 9 o'clock positions, sir, after dilution.
Which is the best dye to use?
ICG, ma'am, ICG.
That is standard.
Yes, ICG standard after 5 styles.
Which is the sentinel lymph node in C endometrium?
Yes, ma'am. Yes, sir. Medial to external iliac. Yes, sir.
No, that is not. The...
Yes, ma'am.
Yeah, others also.
Yes, ma'am. Others are also there. Ma'am, first is medial to external iliac, then obliterate at the obliterated umbilicus and going towards. Yes, ma'am. Then at common iliac and presacral, if no lymph node is found down there, then we can go up to presacral.
No, still obturator still remains sentinel lymph node even in C endometrium.
Okay, sir.
Only if tumor is in the upper portion near fundus, then it changes. Otherwise, we should always first look for sentinel lymph node in the region of obturator node.
Obturator.
Even hypogastric, ventral to hypogastric.
Yes, ventral to hypogastric.
Shikant, when you open, if you see there are a group of nodes who have which has taken the dye. So how do you decide which one is the sentinel out of that? Because it's not always that one node will have taken. It would be sometimes 3-4 nodes already have taken dye by the time you open. So how do you decide which one is the sentinel?
Ma'am, firstly, which dye we are using? If it is technetium 99 we are using, then we take first baseline of the cervix and 10% of the radioactivity we will see. And all those lymph nodes having 10% or more radioactivity than the cervix, we have to remove that. In ICG, we have 4 modes, ma'am. So in ICG, we can see, ma'am, the lymphatic channels in the pinpoint mode, in the green mode.
We follow the lymphatic channels.
Lymphatic channels, yes, ma'am.
The node
yes,
which is first receiving the lymphatic channel, that's the sentinel node.
Yes, yes, ma'am.
I think we are now probably running short of time. So now we have final histopath with us.
Yes, ma'am. Yes, sir.
Is it Dr. Radha?
Yes, sir.
Are you going to read final histopath?
Yes, sir. Yes, sir. Histopathology of main specimen or tumor site endometrium. Tumor size is 6.5 into 6.3 into 1.8 centimeter. Histological type is high-grade adenocarcinoma, query-serous carcinoma, query-endometrial endometrioid adenocarcinoma. ISC is given. Lymphovascular invasion not evident. Biometrial invasion present, that is more than 50%. Adenomyosis not identified. Serosa, lower uterine segment, cervical stromal involvement not identified. Other tissue organ involvement, no. Cervix shows Nabothian cyst, right and left ovary, unremarkable. Left pelvic node 0/12, right pelvic node 0/8, aortocaval node 0/3, omentum free of tumor, peritoneal biopsies free of tumor.
So now we have to make final staging based upon histopathological findings. So what is her staging?
Sir, it will be 2C, more than
P-
50% biometrial invasion and high-grade histology.
And will it change under any circumstances after we get
Sir, if the
molecular marker reports? Will it change?
yes, sir. If we get the poly done, if it is poly mutated, then the stage will be 1A.
Okay.
But
So now
P52
she has a poorly differentiated tumor, and we have these findings with us, more than 50% myometrial invasion. So she definitely needs adjuvant treatment after surgery. So what will be the further line of treatment for this patient?
Sir, SC falls under high risk category according to the ESGO criteria. So she will receive adjuvant, that is by sandwich therapy or sequential therapy.
Out of CT and RT, which is more important in a C endometrium?
Sir, in C endometrium, sir, if the histopath is serous, then chemotherapy is also important. Chemotherapy and RT both are important. If the pathology is MMRD mutant, then radiotherapy is more important.
Yes, correct. So if it is only adenocarcinoma, endometrioid adenocarcinoma, but poorly differentiated, RT has greater role.
Yes, sir. Yes,
But
sir.
as we are getting more and more information for stage 2 and beyond, they give a sandwich treatment. They first start with chemotherapy, 3 cycle, followed by radiotherapy, both external and intravaginal, followed by remaining 3 cycle of chemotherapy.
Yes, sir.
So she definitely needs adjuvant treatment. Do we still have some time, or we have to
What
wind
is
up?
the risk of recurrence in this case, Radha?
Ma'am, in stage 1 and 2, the
No, this
risk of
patient now
recurrence
is
50.
serious. She is high risk. So what is the risk of recurrence in high risk cases?
More than 25%.
Yes, right. So more than 25%.
Yes, ma'am.
Quite likely she is high risk.
Yes, ma'am.
I think we can wind up now. I
Okay.
must thank both of you. You could face our questions. Dr. Dipanvita, any other thing you'll ask them?
No, sir. Thank you.
So you both deserve to pass from our side.
Thank you, sir.
Congratulations.
So, how will you follow up? Means you know the follow ups though still.
Yes, ma'am. First, there are more chances of recurrence in first 2 years. First 2 years, there will be 3 monthly follow-up in which we will do the clinical history taking. The history is most important. We will educate the patient about the symptom of recurrence, which can be bleeding, lower abdominal pain, cough, shortness of breath, and if she has any symptom, we will take the history and then we will do the clinical examination. If they are suspicious, then we will do the imaging. And for the next 3 years, we will do the 6 monthly follow-up and after that, yearly follow-up.
No one.
Mainly clinical. Yes,
Yeah.
ma'am.
Yeah. What is the role of doing MMR, the ISC, and counseling or doing the test for Lynch syndrome?
Yes, ma'am.
Um,
If we are doing the MMR, there will be 4 benefits. First, we can screen the patient who are at higher risk of Lynch syndrome, because if MMR deficient is there are 10% chances that patient will have Lynch syndrome. And second, this can guide us for the adjuvant treatment also. If the patient is MMRD, the patient will be of intermediate prognosis. And third, to prognosticate also. To prognosticate and for the adjuvant treatment, we can give pembrolizumab in MMR deficient.
They're more responsive to immunotherapy.
Yes,
right. So that should have been done in this.
In this, your patient, what is one factor that could tell you that it could be a case of MMR deficient disease? One thing you have mentioned in your findings only. One characteristic of the tumor you have mentioned, which could point at that it could be MMR deficient.
Non-endometrioid.
No.
What was the site of the tumor? MMR deficient tumors are usually in the
Lower uterine
Lower
segment,
uterine
but
yeah, your patient had this lower uterine segment involvement. Oh, not identified. I'm
Yes,
so
ma'am.
I'm so
Good.
sorry. Okay, then fine. Yeah, sorry.
Can I ask one question?
Yes.
Estrogen receptor and progesterone receptors are so important in a CA breast. Do they have any importance in CA endometrium?
Yes, sir. Yes, sir. The ER positive cases have better prognosis than ER negatives is the one thing. When it comes to in the maintenance therapy also, sir, in breast, we are using those aromatase inhibitors. They work well. But here in endometrium, because of mTOR activities, if anastrozole and letrozole, they are used along with everolimus, then they will act better. So, in terms of prognostication and maintenance therapy, ER can guide us.
and when we are doing fertility sparing treatment, they will respond better to hormonal treatment.
Hormonal treatment.
So, thank you very much. Thanks to all of you, Dr.
Thank you,
Meeta,
sir.
Dr. Bhagya, Dr. Dipanvita, and to both of you. If there are no more points, then we will wind up this session and next people are waiting.
Yes, sir. Thank you so much.
Thank you so much.
Thank you, sir.
If there are
you.
questions, who will deal them in the chat box?
Dr. Hafizur Rahman.
Thank
Yes,
you,
sir.
Dr. Afisur, and all the faculties.
Yes, we'd like to especially thank Dr. Bejal for
Thank you.
choosing such an interesting case and two good residents from your department who have presented so well.
Thank you,
We
sir.
have-
Thank you so much.
Good mentorship. Thank you. Thank you.
We have got questions, sir. Can we take those, ma'am?
Yeah, I think questions can be taken.
Yeah, we have some time actually also for our next session.
Yeah, so I'm reading them out. So there's
Yes.
Shri Krishna Agarwal writes, I have a patient at 37 years, marital life 2 years, only withdrawal bleeding, her BMI. I think this is some infertility question. There's nothing to do with endometrial CA, right? We planned for ovarian drilling and endometrial biopsy. Oh, endometrial biopsy showed well differentiated adenocarcinoma, no MRI on no invasion of myometrium. So how to manage? So can I think our students only can answer this question.
Yes, ma'am.
Yes, Shrikant, please.
Ma'am, if she wants fertility sparing surgery, so we can offer this patient because it is 1A and grade 1, ma'am. So
Yes.
fertility sparing can be offered. And the hysteroscopic resection of the tumor should be done, ma'am, after MRI if the lesion is there. And after hysteroscopic resection by grasp method only, tumor should be taken out. Mason et al. Method, ma'am. Firstly, tumor removal, then 4 to 5 mm.
So
Both sides.
three-step
Yes, ma'am. Both
removal
sides and
has to be
then
done.
3 to
Yes.
yes, ma'am.
Done.
Then oral progesterone MPA 400 to 600 milligram per day should be given. And after 6 months, again hysteroscopic guided biopsy should be done. We can offer along with LNG IUS also, ma'am. Along with oral. Mirena insertion should also.
So it's always better to add
Yes,
Mirena
yes,
along with
ma'am.
the oral.
Yes, ma'am. And in follow-up, ma'am, while doing hysteroscopy, we should not be removing Mirena. And 2 consecutive biopsies, we require negative for malignancy with the gap of 3 months. Then she can go ahead for conception.
Yeah, Shrikant, how long can we wait for the endometrium to come
Yes,
back to
ma'am.
normal?
Maximum limit
What's
is
the maximum time?
maximum is 15 months given, but 6 to 12 months is better. But maximum permissible is 15 months, ma'am. As per
Yes. How do you decide whom to give fertility preservation and whom to not?
Ma'am,
What are the
1A.
other criteria beyond stage 1A, grade 1? What are the other criteria?
Ma'am, there should not be any ovarian patient should not be BRCA positive or any if patient is MMRD, means if Lynch syndrome is there, still patient can be offered fertility sparing with the explained risk that patient may develop any other Lynch associated cancers, and the progeny offspring also can can inherit those tumors. And response to the treatment will be less in Lynch syndrome. But in BRCA, definitely we cannot offer, ma'am.
Yeah, and if you have a possibility of doing a P53, obviously we will counsel them that P53 mutants are bad tumors.
Yeah, bad tumors, yes, ma'am. But other markers like PTEN, LCAM, they are not recommended in FSS because management does not change based upon that. Only we can prognosticate, and even in ER negative, we can offer fertility sparing, explaining the patient that treatment response will not be at par with ER positive, but they will be offered.
But
Yeah.
you
I
must
have
tell
only
the patient that it is
have only little
standard of care.
differences of opinion with him. Doing a resection of endometrium at the start is not recommended in all cases. In fact, I have series of 18 such patient, young patient infertile, who were diagnosed with C endometrium stage 1, and I reviewed literature in detail. So doing resection in the beginning is not recommended. It takes about 1 hour's time. You have to instill a lot of fluid, and there is a lot of spillage in the peritoneal cavity. What I usually do, once we have diagnosed, once we've done initial hysteroscopy, taken another repeat biopsy, start on progesterone, either magistrol acetate,
or MPS,
or even Meprate. And in one patient, I gave simply DMPA. Then repeat hysteroscopy after 3 months. And to my great surprise, when do repeat hysteroscopy and repeat biopsy at 3 months, in majority of them, 90%, I found that disease had regressed, but continued treatment minimum for 6 months. If patient and family agrees, give treatment for 9 months and then give a break. And after stopping treatment, she needs to be under intensive follow-up. Almost 33% are likely to have recurrence of the pathology. So to my great surprise, almost 50% patient they conceived. One patient conceived twice. And then came the question that since she is conceived, should we now proceed with the hysterectomy? This is what literature says that after...
Patient agreed, sir, for hysterectomy after the delivery?
Before patient, I was not convinced. I did not have heart to do her hysterectomy. I never did hysterectomy after patient have responded to treatment.
Counsel them to be under follow-up only.
Yes.
But the recommendation is, but patient change their mind after they have changed.
Yes.
Yes.
Agreed.
Yes, and the next case is another patient aged 59, known type 2 diabetes mellitus, obese, with gallstone, came for postmenopausal bleeding. Hysteroscopic biopsy showed EN carcinoma, maybe endometrial carcinoma only. We don't know the grade. And MRI again showed no myoinvasion. So how can we plan surgery, open or laparoscopy?
MIS, ma'am. Laparoscopy.
Laparoscopy or robotic.
Laparoscopy. Better laparoscopy in this case because invasion is less. Standard of care is laparoscopy, ma'am.
Yes. And that's it, I think. These are the 2 questions we had. And the one thing I can just add about fertility sparing is once it comes back to normal and she is motivated for pregnancy, they should directly be sent to a ART center for early pregnancy. Otherwise, when we wait for normal pregnancy to happen, the endometrial cancer may come back again.
Fully agree with Dr. Bhagya. Once we have achieved that regression of endometrium, we need help of ART people. We have only next 3 to 6 months, and she should conceive in these next 3 to 6 months.
Yes.
And then Shri Krishna Agarwal writes, on hysteroscopic, no visible tumor was seen. So it was a small growth, but the biopsy is carcinoma, right?
Yes.
So I think even if there is no growth, it would look like only a hyperplastic endometrium, but the biopsy has proven that it is carcinoma. So we have to go ahead to treat the woman as endometrial cancer only, even if there is no growth. Yes. So I think Hafiz, we are done.
Tulsi, is there any more questions?
No.
No.
So thank you.
There are no further questions.
Thank you, ma'am.
Thank you.
Thank you, sir.
So thank you so much, everyone. I'd like to express my sincere thanks to the students, Dr. Radha Gupta and Dr. Srikant
Yeah, they
Dadi.
did very well. Yes.
Yeah.
I think they deserve applause and they have done wonderful. Thank you so much, both the students and their guiding faculty. Dr. Vijay Manish Patel, Madam has so much interest, and Madam said one day only that please give us opportunity to our students, and that's really encouraging for all the students and for them as well as to participation. And I am sure this is going to be a very much important for all the students, those who are watching, and it will be on record also. So I'd like to sincerely express our sincere thanks from ICO on behalf of ICOG to our faculties, Professor Amita Suneja Madam, Shunesh Kumar Sir, Dr. Bhagyalasmi Nayak Madam, and Dr. Dipanita Banerjee for giving your valuable time on Sundays days for the benefit of the students. And thank you so much from the bottom of our heart and on behalf of ICOG. Thank you so much, ma'am and sir.
Thank you.
Thank you, Hafiz, and thank you for doing it for the last 4 years so
4
religiously.
years. And Sundays. 4 years, Sundays.
Second Sunday.
Dipanyata was kidding the other day me on Sunday, that is, we are having sparing your second Sundays of the month from the last 4 years. And it is not only Dr. Ashok Kumar, Dr. Ashish Mukherjee is always there on all the Sundays. And it was Dr. Ashok Kumar sir. We proposed that it will do on Sunday for the benefit of the students. So this is, we have entered into the 5th year of the program, and it is because of all the students, those who actually encourage, and they keeps on sending messages as well for the topics as well as what they want actually in the different sessions. And then especially Dr. Ashok Kumar has been very instrumental in guiding also me in what are the things to be included, what are not to be included, including the ICOG chairperson, the current Dr. Parag Binyala. He is made sure that he's always there in each and every program. He will be at least there and he'll be always inquiring me, Hafiz, what is the next program and what is the next session is going on. So that keeps me encouraged also. So thank you so much.
And very good afternoon, Arup sir. It was very interesting. I think we learned also.
Aziz sir is also our backbone in different times, because whenever there is anything with dummy doll or any other topics, I usually keep a turn on to him, sir, please be there. And he's always there.
Your session is also very interesting.
Textbooks are widely read, sir.
Thank you. Dr. Habijot, there are 2 questions, I think, in the chat box. Very basic question. Can I say or later?
If it is there, quickly you can say anything. Otherwise, let us.
There are 2 questions in the chat
Yes,
box.
sir, yes.
Huh? You have not.
Sir, please also show various findings we get on abdomen Leopolds in different presentations. Sir, I think we'll have it in a different day on a later one.
Yeah. I think that will be the basic question. That is the actually
we'll have in a different, because
and full and happen. We can another day we can. You say I can save, otherwise.
Okay, sir. We'll have on a free and demonstration session. We'll take your help on this later on, sir. Because on the leopard maneuver, because they are asking, so how to take, I think, all the leopards, we can have a session on that answer.
Okay. That is a very interesting thing.
Yes, sir. Yes. So thank you so much, sir. We'll move on to our session 3. Yes. So with that, continuing that case discussion aspect, so we wanted to have more detail on understanding pathology in endometrial cancer. So we have with us Dr. Divya Midha. She is Senior Consultant, Department of Oncopathology at Tata Medical Center, Kolkata. So I'd like to Dr. Divya Midha. She will be taking us on different aspects of pathology of endometrial cancer. Dr. Divya, are you there?
Yeah, I'm there. Hello.
Yeah.
Good afternoon, everyone. At the outset, I would like to thank Dr. Rahman for giving me this opportunity, and of course, FOGSI and ICOG for having me here to speak on a Sunday afternoon. I must say, you all are a very focused group. I think I'm the lone pathologist today. It's nice to see Bhagyalakshmi Naik, madam. We do
Divya, you are not
interact.
alone. We are all there with you.
I'm so glad. Thank you so much for having me here. Thank you. So shall I share my screen, Dr. Rahman?
Yeah, sure. Yeah,
Okay.
sure. Please go ahead.
And I'm audible, right? I assume I'm audible, right?
Yeah, you are audible. Perfect.
Okay. Right. I'll just use my pointer. Just give me a minute. Yeah. All right. So thank you everyone for having me here. I will speak very quickly. And I can see that all of you already are quite aware with the changing landscape of endometrial cancer. And just to let you know that we are all equal stakeholders in managing patients with endometrial carcinoma. And now that you've seen the 2023 classification, the FIGO staging of endometrial cancer, you know that the pathologist is a very integral part of treating a case of endometrial carcinoma. So with that, I would quickly start going to my slides. You are all aware of the traditional dualistic Bokman classification of endometrial cancer, where we have the type 1 and the type 2 cancers. The type 1 were the endometrioid cancers. The word endometrioid means that it resembles a normal endometrium. And these were generally low grade. They arose in a background of hyperplasia. This was a more common type of cancer, which we all saw. And they used to be estrogen dependent, seen in obese women, perimenopausal, associated with risk factors. The less common one was the type 2, which was basically non-endometrioid. By non-endometrioid, we mean the serous or the clear cell or anything which did not resemble the normal endometrium. So these were considered, of course, to be high grade. They were rising in a background of atrophy. The pathologist didn't see them as often as the endometrioid cancers. They were in estrogen independent situations. The women were thin, postmenopausal, and did not have any risk factors. Even in the 1980s, it was found that, they were different tumors. The type 1 behaved better, the type 2 behaved aggressively, and even genetically, the thought process was that they were arising from different mechanisms. So 30 years later, in 2013, the TCGA published the Integrated Genomic Characterization of Endometrial Carcinoma, and they said that these heterogeneous group of endometrial carcinoma was actually, you can classify them into 4 non-overlapping groups, which was the ultra-mutator phenotype, which is a POL-E mutations. This was seen in 4 to 12%. The hyper-mutator phenotype caused by DNA mismatch repair deficiency seen between, say, 20 to 30%. The copy number high or the TP53 mutated phenotype, which was the worst prognosis, seen between, say, 10 to 20%. And if it didn't fall under these 3, they were the no specific molecular profile or the copy number low endometrial carcinomas. Now, this picture shows you the relationship between the traditional histological classification and the molecular classification here. Now, the thicker the line, the stronger is the association. Now, you can see a thick black line. The endometrioid carcinomas, FIGO grade 1 and 2, were generally the no specific molecular profile. And the serous carcinoma here was the most commonly the P53 mutated tumors. Look at these other lines. They are going in all directions. For example, the endometrioid carcinoma, FIGO grade 3, could be anything molecularly. It could be NSMP, it could be MMRD, it could be P53 mutated, it could be POLI. And even the clear cell carcinoma group, it could be anything molecularly. So whereas molecular classification gave you 4 non-overlapping groups, on histology, it was everywhere. Okay, so this is the 2014 WHO classification, which emphasizes on the morphological subtypes, but the WHO 2020 classification acknowledged the molecular subgroups of endometrial carcinoma, but because WHO has an international appeal, they still say that we should classify tumors on the basis of the histotype, taking the aid of immunohistochemistry, because molecular profiling is not possible in all countries. Okay, so the basic idea is a pathologist needs to differentiate between endometrioid and non-endometrioid. That is the first important rule. And with the help of the HNE stain, and of course with the help of IHC as much as possible, and then go on to classify it molecularly. Now, the good news is that the TCGA subtypes can be replicated in our lab using IHC markers. For example, for the copy number high, which is the TP53 mutated group, we have the P53 IHC. For the hypermutated or the MSI high group, we have the MMR IHC. Now, for the poly mutation, however, there is no surrogate marker and we have to rely on molecular tests. And of course, if it is nothing, if it's not poly, if it is not MMR, it is not P53, it automatically falls into the copy number low or the no specific molecular group. Okay. So the role of the pathologist is on the endometrial biopsy to accurately histotype the tumor and to give a tumor grade. So very important to type the tumor and to give the tumor grade. Then on the resection specimen, we are supposed to confirm the tumor type and the tumor grade and go on to stage the tumor as accurately as possible. The molecular subtyping, wherever possible, should be done on the biopsy itself. And the reason is the biopsy is the best fixed material we have. So it is preferred that we do the molecular testing with the help of IHC and with the help of poly on the biopsy itself. But it is not possible to do that in all centers. We do agree with that. But wherever possible, we should be able to do ER, PR, P53, and at least two of the MMR markers, that is MSH2 and MSH6 and PMS2 on the biopsy itself. Now, for example, in my hospital, we do the ER, PR, P53 and all 4 MMR IHCs on the biopsy itself. And then the specimen is subjected to the resection and the staging. And then we do the confirmation of the tumor type and the tumor grade, and we stage the tumor. And the poly testing is done on the resection specimen. But this can vary from institute to institute. Now, after the molecular subtyping is available and the staging is available, the risk stratification is done by the clinicians for further management. And the ESCO, ESTRO, ESP guidelines are there for the management of patients with endometrial carcinoma. And there are defined prognostic risk groups when the molecular classification is not known and when the molecular classification is known into low, intermediate, high, intermediate, and high risk. And as you all know, everything in this is dependent on the pathology report. So please be good to your pathologists, be very kind to them. All right. So the pathological parameters for reporting, which we must tell you, is the tumor size, which may predict the lymph nodal involvement, the tumor histotype and the tumor grade, which is important for adjuvant treatment. We should give you an accurate depth of myometrial invasion to distinguish PT1A from PT1B. We should tell you whether the cervical stroma is involved or not, because it implies PT2. The importance of uterine serosal and adnexal involvement, PT3A. Parametrial and vaginal involvement, PT3B. We should give you if the lymph nodes are involved or not, with the size of the metastasis to determine the end stage, and the biomarkers wherever possible, MMR, P53, HER2, which is important from the aspect of Lynch syndrome, genomic subtyping, and treatment implications, which I'm going to talk about shortly. And of course, we should give you the PTNM stage and the FIGO staging as per the 2023 criteria as much as possible to guide the adjuvant treatment. And of course, we have a new kid on the block, that is the LVSI. We should be able to tell you if there is no LVSI, focal LVSI, which is less than 5 vessels, or substantial or extensive LVSI, which is 5 or more vessels on a single HNE glass slide. All right. Now, coming to the role of ancillary testing in endometrial cancer, and we often ask for IHCs, which implies that we are requesting that the patient pays more right at the outset. So it is very important that you as clinicians should know why we are asking for such a situation, why we are asking for additional IHCs. And these are the reasons. That diagnostic IHC will help us to subclassify endometrial cancer into different histotypes. Then again, the second important implication is sometimes when the tumor is in the lower uterine segment, as Madam just spoke about, we need to differentiate whether this is an endometrial primary or this is an endocervical primary involving the lower uterine segment. So this is also very important from the treatment perspective. Coming over to biomarker testing, we need to do IHCs for MMR proteins. We need to do IHC for HER2 and the P53 IHC. And the last and most important is the poly testing in endometrial carcinoma. So these are the various ancillary tests that need to be performed in endometrial carcinoma. Now, the current FIGO 2023 staging depends upon the histotyping of endometrial cancers. You're all aware of that. The two non-aggressive or low-grade endometrial cancers are only two: endometrioid carcinoma, FIGO grade 1 and FIGO grade 2. And the aggressive or the high-grade endometrial cancers are the following: FIGO grade 3 endometrioid carcinoma, serous carcinoma, clear cell carcinoma, undiff, D-diff carcinomas, carcinosarcomas, and mixed endometrial carcinomas. So IHC can be very useful besides your normal HNE to distinguish all these subtypes. For example, the endometrioid grade 1, grade 2 are generally ER and PR strong positive. They lack P16. They are generally P53 wild, and they're negative for napsin. Endometrioid grade 3, on the other hand, can be P53 mutated. The serous carcinomas show strong diffuse block positivity for P16 and are P53 mutated. The clear cell carcinomas, however, can be P53 wild or sometimes even mutated, but they show strong napsin positivity. So this is how immunohistochemistry can help us, the pathologists, in subtyping the tumor. Now, as I said, it's another very important, ancillary testing in endometrial cancer that we do is to differentiate an endometrial primary from endocervical primary. We do this on the basis of histology for sure, but sometimes we definitely need immunohistochemistry to make this distinction. The endometrioid carcinomas are ER and PR positive. They lack P16 block positivity. They are positive for Vimentin, and the endometrioid carcinomas can show MMR loss. Now, the endocervical carcinomas are ER and PR negative. They show strong P16 positivity by the HPV mechanism. They are CEA positive and Vimentin negative, and generally MMR intact. So we can use this immunohistochemical algorithm to distinguish endometrioid endometrial carcinomas from endocervical adenocarcinomas on the basis of IHC. Of course, microscopy and cross features also help, but IHC puts a stamp on it and says this is endometrial versus endocervical. Now coming to the important use of biomarker testing. So let's talk about P53 IHC. Now the P53 wild IHC is characterized by a heterogeneous staining. Basically, we get, this is what is heterogeneous staining. There are some negative cells. This is a tumor. This is an endometrioid carcinoma. This is showing some blue cells, which is not staining, some lightly stained cells, some darker brown cells. So there is a heterogeneous staining. This is a typical wild type P53. However, the abnormal mutated P53 are of the following types: an overexpression type, a null type, a cytoplasmic type, and very, very rarely you will have a mutated P53, but it is showing wild on your IHC. And that's a very, very rare situation. So this is the most common form that we see, which is the overexpression mutant P53, where every cell is dark brown. Each and every cell is dark brown. This is known as the mutant P53. This is actually a serous carcinoma arising in a polyp, where you can see the normal endometrial glands of the polyp not showing the dark brown, whereas the tumor is showing the dark brown staining. This is your null P53, where the tumor is showing a blue sort of null staining, no staining, whereas your background is showing the brown staining. So this is your internal control, your background cells which are showing the staining, but your tumor is zero. This is your null or the mutant null type of P53. And this is your cytoplasmic P53, which is, again, another rare mutant type of P53 staining. So this should be there in your report, and you should discuss it with your pathologist whenever you're discussing the P53 staining patterns. Now, coming to the HER2 testing in IHC, what happens is that the endometrial serous carcinomas and carcinosarcomas you know that they're very aggressive tumors with low efficacy of the traditional platinum-based chemotherapy and high rates of resistance and recurrence. HER2 overexpression has been seen in 30 to 35% of serous carcinomas and 15 to 20% of carcinosarcomas, and it is a potential target for anti-HER2 therapy. And there are, scoring guidelines for trastuzumab use based on the enrollment criteria for this phase 2 clinical trial, where it is based on breast, but it's a little different also because you use a 30% staining is used here, and a basolateral lateral membrane staining is also taken into consideration. Now we also have, as for the Destiny Pan tumor HER2 trial for trastuzumab deruxtecan use, we also have a scoring algorithm has come for that also in the CAP and should be followed by your pathologist. Now coming to your MMR and MSI testing in endometrial carcinoma, why should we test? You're all aware for Lynch syndrome screening, you should test it. It also helps in histotyping. MMRD tumors is usually seen in the endometrioid type of endometrial carcinomas. It's also used in genotyping. As you can see that we have a special MMRD group in the current molecular classification of endometrial cancer. It's got huge treatment implications. They are unlikely to respond to conservative treatment with progesterone. So it's very important that when you're considering a patient for progesterone therapy, on the biopsy itself, your pathologist should perform the MMR IHC. These tumors show a high likelihood of LVSI, suggesting or justifying a sentinel or a nodal dissection. And as was discussed in the last case in the question answer session, they respond quite well to radiotherapy. MMR deficient tumors have an intermediate prognosis, as you can see by this graph, and they are predictive for targeted therapy with immune checkpoint inhibitors. So all cases of endometrial carcinoma should be tested for MMR IHC. Now, how does one test for these MMR defects? You can do the MSI-based testing by PCR-based methods. However, this is a more expensive method, longer TAT. This test is not easily accessible to pathologists. It is carried out on DNA extracted from tumor tissue and therefore requires a high level of expertise. And even if you detect MSI by the PCR method, you will have to do it do an IHC to identify the gene which was involved. So an easier way is to do it by the MMR IHC. And the reason is IHC is a cheaper test. It's easily accessible to pathologists. It's amenable to EQUAS. It allows correlation with morphology, and it identifies a defective protein, thereby guiding your downstream testing. And both MMR and MSI have comparable sensitivity and show approximately 96% concordance. So what are the MMR IHCs that we use in the lab? MLH1 and PMS2 and MSH2 and MSH6. So this is your a tumor, which is an endometrioid carcinoma. And this is an MMR deficient, case where you can see that your internal control, where I'm showing these brown dots, this is your stroma, which is showing your staining, but the tumor nuclei are not showing the staining. So there is a loss of nuclear staining of one of these MMR proteins, and therefore this is an MMR deficient tumor. Okay. Now, what is a normal result is sometimes we can do it by the 4 IHC method or the 2 IHC method. So if all these IHCs are intact nuclear staining, or if you can start with the 2 IHC method, if they're showing intact nuclear staining, there is no immunohistochemical evidence of mismatch repair deficiency. Now, there are abnormal results. If MLH1 and PMS2 is lost, it is an abnormal test. This is usually sporadic and rarely Lynch syndrome, and it is associated with MLH1 promoter hypermethylation, which can be tested in the lab by a methylation-specific PCR. So this is one of our tests. We do MLH1 promoter methylation in our lab, and you can see that in this particular case, there was MLH1 promoter hypermethylation, where a PMR value of more than 4 indicates MLH1 promoter methylation. Now, the second abnormal result is if you get MSH2 and MSH6 loss, or an isolated MSH6 loss, or an isolated PMS2 loss, or a MLH1 PMS2 without a methylation. All these 4 situations are associated with Lynch syndrome, and a germline testing is indicated. So this is the British Association of Gynepathologists guidelines, where all endometrial cancers are tested by IHC for MMR proteins. And if all the tested markers are expressed, it is not Lynch syndrome. If there is loss of MLH1 and PMS2, you do the MLH1 promoter hypermethylation testing. If it is detected, it is not a Lynch syndrome. If it is not detected, you do a germline testing. However, if there is loss of MSH2 and 6, only MSH6 and only PMS2, you will directly go for germline testing. So this is a great guideline to help pathologists and to tell the clinicians as to what should be done further. Now, MMRD testing can also be done by NGS, which you do the direct germline or somatic MMR mutation testing. It tests for tumor mutational burdens. It determines the percentage of indel mutations, and such testing strategies are likely to evolve rapidly in the future. With this, I would like to present a case to show you how we report in the laboratory and how things have evolved in the last 3 years in our laboratory. So this was a 58-year-old female presenting in February 2022 with postmenopausal bleeding. Her MRI pelvis showed a 3-centimeter lesion with more than 50% myometrial invasion. The cervix was not involved and no lymph nodes were involved. Her CT thorax and abdomen were within normal limits. She had undergone an endometrial biopsy at an outside center, and she had a report which said endometrioid endometrial carcinoma. So in this situation, we can see that they have histotyped the tumor, but they have not graded the tumor, correct? So obviously the first thing our clinician will do is going to ask us to review the slides and blocks. So the slides and blocks were reviewed at our center, but the pathologist, it wasn't me, it was my colleague who said, this is a high-grade endometrioid carcinoma. So basically, she did not want to do a FIGO grade 1, grade 2, grade 3. The reason was sometimes it gets tricky, but it is enough to sometimes just tell your surgeon that this is looking endometrioid and this is perhaps high grade. Now, the reasons, I'm going to tell you the reasons later why she could not accurately say what it was. Now, this patient with this information underwent a THBSO, bilateral pelvic lymph node dissection, para-aortic lymph node dissection at our hospital. And these are sections from the resection specimen. So I know none of you are pathologists here, but you'll have to believe me that this is looking rather endometrioid. By endometrioid, I mean that it resembles a normal endometrium. So in this picture, it looks like an endometrioid carcinoma of endometrioid type back-to-back glands. Okay, so this is your normal endometrial glands. These are looking like that. Okay, so this was looking endometrioid in this area. And you can see that these were looking rather endometrioid. Now, in certain areas, it started looking more solid. So maybe it's a grade 3 endometrioid. But then in certain areas, it started looking very serous, very high grade, with mitotic figures, very prominent nucleoli. It started looking very high grade. Certain areas showed some squamoid differentiation. Again, very high grade areas were there. Again, mitotically very active. There were lots of tumor infiltrating lymphocytes. And this is section from the cervix where it was seen to invade the cervix also. Okay, you can see this is the endocervical glands here, and the tumor was invading the endocervical stroma. So the key histological features was it was looking like a high-grade endometrial carcinoma. It had intratumoral heterogeneity. Somewhere it was looking endometrioid, somewhere it was looking serous. It had an ambiguous look. There were tumor giant cells, there were tumor infiltrating lymphocytes, there were peritumoral lymphocytes. It was strongly positive for ER and PR. P16 was lack of block positivity. This is showing you the control here, which is a block positive control. This is showing lack of block positivity. P53, this is your control. The pathologists at that time called it query wild type staining. There was some staining, but it was not as strong as the control. All the MMR IHCs were done and they showed intact nuclear expression. So the tumor invaded more than half of the myometrial thickness. The cervical stroma was involved. There was no LVSI. The ovaries and fallopian tubes were free of tumor. The parametria were free. The pelvic lymph nodes, 0 out of 13, left pelvic, 0 out of 11, para-aortic, 0 out of 14. There was a presacral node also 0 out of 2. So ER and PR positive, P53 wild, MMR retained, so MMR proficient. The pathologist called it endometrioid endometrial carcinoma, FIGO grade 3, PT2 and 0. Now, this was March 2022. and this was query wild. Now, the clinician heard query wild and said, okay, no, I'm worried. This could it be P53 mutated? So we said, no, it's most likely looking wild to us, but this is how it is. So they said, okay, because we said it's P53 wild, they said, okay, high intermediate stage, high intermediate risk, molecular classification unknown because something was missing. And because the idea was that somewhere this is P53 query wild, they planned for chemotherapy followed by radiotherapy. And the patient got the first cycle of chemotherapy in March 2022. But at the same time, this was a time where we were trying to validate our poly test. And this was one of the first tests that we used to, validate our poly test in our lab. And I thank my colleague in molecular pathology, Dr. Sushant Vinarkar, who was working very hard on standardizing this test. And this particular case was found to be positive for missense variant at exon 9. And this was actually a POL-E ultra-mutated endometrial carcinoma. It was not a serous carcinoma. It was not a grade 3 endometrioid carcinoma. And as you know, POL-E cancers have a very favorable clinical outcome. And now that the molecular classification was known, from a high intermediate risk, it became a low risk tumor. And the treatment plan after POLI, further chemotherapy and radiotherapy was deferred in the MDT, and the patient is doing well on last follow-up in May 2025. So the POLI ultra-mutated endometrial carcinomas comprise 10% roughly of the endometrial carcinomas. They're seen in relatively younger patients who have a high mutational burden and present with a low stage. Morphologically, as I showed you, they can look very high grade, very ambiguous. They can look like a mixed, we don't know how to, classify it. That is why, they were not able to really classify, and one person had just called it endometrioid in the biopsy. And we just called it looking high grade initially. So morphologically, they look very high grade, but molecularly, they are many of them turn out to be poly, and they have a really, really good prognosis. And the reason for this good prognosis is that they are, a very ultra mutated tumor with a lot of tumor infiltrating lymphocytes, and this enhanced T cell anti-tumor response plays a very important role in the favorable prognosis. And the implication is a treatment de-escalation for stage 1 and stage 2 poly cancers. And the pathogenic poly mutations are 11, all in exons 9, 11, 13, and 14. The functional mutations occur in the exonuclease domain, but not all mutations in the exonuclease domain are functional. Very infrequently, mutations outside the exonuclease domain can be functional. The non-functional poly mutations should not be considered as a poly case. The poly mutation testing is done by NGS, Sanger sequencing, hotspot, single nucleotide, snapshot assay, and droplet digital PCR. In my hospital, we have a separate molecular pathology department, and they conduct these tests there. Now, the multiple classifiers, these are 3 to 5% of endometrial carcinomas, which can harbor more than one molecular classifying subtype. But, you can classify them as such. If a tumor has a pathogenic poly mutation in the exonuclease domain and is P53 abnormal, they should be classified as poly mutated because the P53 is most likely a passenger mutation. If the tumor is MMR deficient and P53 abnormal, it should be classified as MMR deficient. If the tumor is pathogenic, polymutated, and MMR deficient, it should be classified as polymutation because POL-E supersedes MMR supersedes P53. However, a non-pathogenic polymutation and an MMR deficient or P53 should not be classified as a POL-E. So you have to know, or your molecular pathologist should give you that information, whether it is a pathogenic or a non-pathogenic POL-E mutation. So the ideal situation is that one starts with the POL-E testing. If the POL-E is pathogenic, it is classified as a POL-E mutated cancer. If it is wild, you should then do the MMR testing. If it is deficient, it's an MMR deficient cancer. After this, the P53 IHC should be done. If it is mutated, I showed you those mutation patterns. It is a P53 abnormal endometrial cancer. And if it is wild, then it is a no specific molecular profile endometrial carcinoma. Now, it is very difficult to do poly on all cases because not all patients can pay for the testing. However, one can use the BAGP guidelines to or this algorithm to provide poly testing in those cases which is essential. So group 1, so on the biopsy, one should do MMR, P53, ERPR on all cases. The MMR abnormal or the P53 abnormal group should be subjected to POL-E. Then the tumor should be subjected to surgical staging. The low grade, low risk ones or the high risk ones, you need not do a poly testing. It is this group 3 of stage 1 to 2 non-endometrioid, grade 3 endometrioid, or the ones which are ER negative or with substantial LVSI. These are the ones where the poly NGS testing or the poly testing is recommended. So this is actually some old data from the poly testing. Now we have around 300 cases. We are about to publish it. And our poly mutation, our rate is around 4.6% in our hospital. And it costs around 8,000 rupees and the turnaround time is around 10 days. Now coming to the FIGO 2023 staging, this is the older staging, which was an anatomical staging. And now you're all aware we have the FIGO 2023 staging. And the important thing is it relies heavily on pathology. So as I said again, a lot rests on the pathologist's shoulders. It is based on an important distinguishing feature, that is you have to distinguish aggressive from non-aggressive endometrial cancers. It takes into account LVSI. It takes into account the size of the lymph node mets. The synchronous endometrial and ovarian endometrioid carcinomas have been dealt with, and it integrates molecular classification into the staging of endometrial cancer. And of course, as very well elucidated by the cases, the stage 1A poorly mutated and the stage 2C P53 abnormal endometrial cancers are now very important to understand from the molecular perspective. So ideally, one should do the histotyping, the grading, and the molecular classification on the endometrial biopsy itself, because that is the best material available. And this will give you an idea to classify tumors into the POL-E, MMRD, the NSMP, and the P53 abnormal group. And a lot of treatment strategies can therefore be based on these molecular groups. And we know that there are studies using immune checkpoint inhibitors for patients with MMRD and PARP inhibitors and anti-HER2 for the patients with P53 abnormal group. And of course, you must be aware of the comprehensive rainbow trials where patients with POL-E mutated endometrial cancers, the de-escalation of adjuvant treatment will be studied in a registry, and the MMRD group, the radiation will be compared with radiation plus checkpoint inhibition. And for the P53 abnormal group, chemoradiation will be compared with chemoradiation followed by PARP inhibition. And for the NSMP group, adjuvant chemoradiation will be compared with approaches involving hormonal treatment. So with this, I thank all of you for the patient hearing. I thank my team at Tata Medical Center, Kolkata, the Department of Histopathology, Molecular Pathology, Cytogenetics, and the Gynae Oncology DMG led by Dr. Jyoti Pomik for this collaborative study and this collaborative efforts towards treating patients with endometrial carcinoma. Thank you very much.
Thank you so much, Dr. Divya Mirza Madam, for your extensive as well as comprehensive lecture on endometrial cancer. And I'm sure it is going to give us at least lots of understanding, whatever we can retain, but it will be very much helpful to all of our students as well as all the delegates. So thank you so much for your
Thank you, Dr. Thank you for having me here. Thank you.
So, Divya, as usual, it was excellent.
Yes, ma'am.
Thank you
and
very
so
much,
simplified.
Madam.
Yeah, because always this molecular is always a problem for me. I myself get so confused about that. Thank you so much.
Thank you so much, ma'am. Thank you very much. Thank you for having me here.
Thank you so much. So we'll move on to our next session, that is on interesting session that is we have added from this year, that is quiz program. So the quiz on endometrial hyperplasia and endometrial cancer, and The program is conducted by under the chairperson of FOGSI quiz committee. So Dr. Archana Kumari and her team. So we have today with Dr. Rijesh Ravi, Dr. Nazia Israt, both are a coordinator of quiz committee. And Dr. Archana Kumari may be busy today, but they will be conducting the quiz today, Dr. Rijesh and Dr. Nazia. Dr. Rijesh, are you there?
Yes, sir. Thank you, sir. Thank you for the introduction. I hope we have two quiz masters along with Dr. Apala and Dr. Nasia. Yeah. Nasia, madam, are you there?
Hello, Rajesh.
Yeah, madam. Yeah.
Hi, everyone.
Yeah,
Very
good evening,
good
madam.
afternoon to
So
everyone.
we are right on time, I guess. So it has been an honor for the quiz committee to associate this year with ICOG for the quizzes. And this time we have this topic on endometrial hyperplasia and endometrial cancer. And in the absence of Dr. Archana Kumari, I thank the ICOG team once again for this wonderful opportunity. And we have a few questions on endometrial hyperplasia as well as malignancy. And most of the questions will be done by Nasia Madam, who is the coordinator, North Zone coordinator. And Dr. Appala will also join, Madam. So start some few questions I will also do. And I will share the question, the code soon. And by that time, Dr. Nasia Madam can have a few words. Over to you, Madam.
Thank you, Dr. Rajesh. Actually, before starting this quiz, I just want to welcome all the participants, and I ask the participants to please join in the quiz so that maximum number of people can join the quiz. So before starting, we should give them the code for joining that Kahoot app, I think, Dr. Rajesh.
Yes, madam. I'm sharing, madam.
Yeah.
Okay. Okay, so the code for joining this Kahoot is 365014. I request everyone who is there or all those who have been shared this ICOG PG quiz, please register and participate. So on screen we can see how many of them are playing with us. This interesting quiz. All the presenters before they have elaborated much about endometrial hyperplasia as well as endometrial carcinoma. And in the recent year, I think there is a lot change in the management of endometrial cancer when that molecular classification has came, and many centers in India are doing it. So about the molecular classification, new FIGO 2023 staging, and the new avenues in the management of endometrial carcinoma. So it is a must area we should know because there are in India nowadays cases of endometrial carcinoma is increasing day by day. Many people have joined. I think there are 9 first line mein hai, and then 22 people. I think we have joined the quiz.
Madam, we'll wait for another 2 minutes and we'll start, madam. And I request the participants to give your name as the nickname so that we don't have confusion rather than 1, 2, 3, 4, 5 or SD.
Some of the participants, they join with short forms. So it is difficult to recognize. I think if you join with your full name, at least first name, then it will be easy. And you, okay.
So we have around 35 questions planned. Initial 5 questions I'll be doing, then I will hand over to Apala, and Nasia madam will do the final showdown. Final 15 questions madam will be doing. And
okay, definitely.
So
more participants are joining.
people have difficulty to join, you can directly scan the QR code displayed and have the scan and directly enter into the queues. Or you can go to kahoot.it, kahoot.it, and enter the game pin. Or if you have any Kahoot app installed, you can press the center button and enter the game pin.
Few people, they still with KK, HS, SD. Please put your first name like Anand, Arham, Kani, Sumina, Sabu, Sahira, Nish, R. Patnaik, Meghna, Supriya, Chandrai, Meghna, Archie, Swatika, Mukul. Who is then? Dr. Shrikant, who was presenting, also joined. Anyone who is having difficulty in joining, please, you can put it in a chat box or rescan the QR code or enter that pin on Kahoot. Hi, Apala, you will be conducting first after Dr. Rajesh.
Yes, sure, ma'am.
I think we'll start. I will keep the session open so that anybody want to join. So once again,
Dr. Rajesh, please proceed.
So once again, thanking ICOG for this wonderful platform for quiz committee, and we're starting with the quiz. So ICOG quiz July 13, 2025. So we'll start. So we'll start with the first questions. So the first question, which of the following is the strongest risk factor for endometrial carcinoma? Whether it is nulliparity, whether it is OCP, whether it is obesity, whether it is smoking, which is the strongest risk factor for endometrial carcinoma? Only 5 seconds left. Yes, obesity is the strongest risk factor. I am surprised two people has gone with OCP. OCP is actually protective. And among the other risk factors, obesity is the major risk factor. So with that question, we have a scoreboard with Chandri at the top. We'll move to the next question. Fingers on the buzzer. The most common presenting symptom of endometrial carcinoma is pelvic pain, abdominal bloating, postmenopausal bleeding, dyspareunia. This all may be the presenting symptoms of endometrial carcinoma. What is the most common presenting symptom of endometrial carcinoma? Yes, it's almost 100%. Only one person has got it wrong. It's postmenopausal bleeding. Actually, we are just warming up. We have questions on molecular and all cancer, HNPCC, everything coming later. So we'll start slowly. So these questions everybody is answering, and the person with the fastest finger will get maximum points. So Chandri is still at the top. So gold standard for diagnosing endometrial carcinoma is whether it is pap smear, MRI, endometrial biopsy, or transvaginal sonogram, which is the gold standard. Everything can help in diagnosis of endometrial carcinoma, but which is the gold standard? Five more seconds. Again, it's 100%. Endometrial biopsy is the gold standard, no confusion at all. But sometimes if you are late, you may have lesser marks. So Supriya has pushed on to the first place. Which of the following histological subtypes of endometrial carcinoma has the worst prognosis? So we know there are different types of histology. Grade 3 endometrioid carcinoma, clear cell carcinoma, serous carcinoma, mucinous carcinoma. Which has the worst prognosis? So that was a little bit confusing. I
See.
read. So serous carcinoma has the worst prognosis, even worse than the grade 3 endometrioid carcinoma. So Chandra is back at top. We go to the next question. Which receptor status is predictive of response to progestin therapy in advanced or recurrent endometrial carcinoma? Whether it is P53, HER2, ER, or K67. Five seconds left. Yes, as majority has got it correct, it is estrogen receptor positivity is a good predictive for the response to progestin therapy. So Patnaik has come to the top. Yeah. Next question. Which of the following is an absolute contraindication to fertility sparing management in endometrial carcinoma? Absolute contraindication. Whether it is grade 1 endometrial histology, whether it is stage 1A with no myometrial invasion, whether there is presence of LVSI, whether there is desire for future fertility. I should have put it as no desire for future fertility anyway. Yeah, but everybody has got it correct. Presence of LVSI is an absolute contraindication for fertility sparing management in endometrial carcinoma. So we'll go to the mark. Yeah, Patnaik is still leading. And with that, I hand over to Dr. Apala. Apala, you there?
Thank you, sir, and a very warm good afternoon to everyone. We'll start with the first question of round 2 now. Risk of endometrial hyperplasia without atypia progressing to endometrial cancer is less than 5, 5 to 10, 10 to 15, or 20%. Without atypia. So the correct answer is less than 5%. Most of you have got it right. Coming to the next question. Okay, so Tara moving over to the top. What is the dose of oral medroxyprogesterone when given for the treatment of endometrial hyperplasia without atypia? Cyclical 10 to 20 milligram per day, continuous 10 to 20 milligrams per day, cyclical 40 to 60 milligrams per day, or continuous 100 to 160 milligrams per day without atypia. Yes, so the correct answer is continuously it should be given for 10 to 20 milligram per day. Tara again taking the top score. "12 months follow-up of hyperplasia without atypia on oral progesterone therapy and biopsy shows no histological regression. What will you do now? Increase the dose of oral progestogens, switch to LNG-IUS, change the type of oral progestogen, or perform a hysterectomy for her?" So the correct answer is on 12 months follow-up, you should always perform a hysterectomy if there is no histological regression. Sumina moving up. Percentage of endometrial cancers confined to the uterus at the time of diagnosis are 10%, 30%, 50%, or 80% of them. So 80% of the endometrial cancers are confined to the uterus. So they are relatively good prognosis, diagnosed early. Sumina again taking the top. Preferred adjuvant treatment for stage 1B grade 1 endometrial carcinoma is observation, vaginal brachytherapy, EBRT, or a systemic therapy. By systemic, I mean a chemotherapy. For stage 1B grade 1. So it's a vaginal brachytherapy. If it was stage 1A, it could be observation. For 1B, vaginal brachytherapy. Sumina again taking the top. The order of pathological testing for molecular analysis in endometrial carcinoma is P53 pole MMR, MMR P53 poly, poly MMR P53, or poly P53 MMR. So what is the correct order with which you will do the perform the molecular analysis? Most of you have got it right. So poly followed by MMR followed by P53 is the right order. Preferred first imaging modality to confirm a clinical suspicion of recurrence after treatment of endometrial cancer. Please note, recurrence after treatment for endometrial cancer is CT, MRI, USG, or an FDG PET. Yes, to confirm the recurrence, always a CT scan is the preferred imaging modality. So most of you have got it wrong this time. Sumina again taking the top. In surgical staging for endometrial cancer, omental biopsy or omentectomy, let's say, should be performed in all of the following histologies except serous, clear cell, carcinosarcoma, or endometrioid carcinoma. So endometrioid is the right answer because it should be performed in all high-grade histologies. So most of you have got it right this time. Coming to the next question, the most accurate imaging technique for pre-operative assessment of endometrial cancer. Now we are talking about the pre-operative assessment. USG, MRI, CT, or PET. MRI is the correct answer. Most of you have got it right. The FIRES trial in endometrial carcinoma analyzed role of adjuvant chemotherapy in endometrial carcinoma, role of laparoscopy in endometrial carcinoma, role of sentinel lymph node biopsy in endometrial carcinoma, and role of immunotherapy in endometrial carcinoma. The FIRES trial. Yes, it analyzed the role of sentinel lymph node biopsy in endometrial carcinoma. Congratulations to most of you. Coming to the next question. Stage 1A grade 3 endometrioid type, MMR and NSMP with no LVSI comes under which endometrial carcinoma risk group? Low risk, intermediate risk, high intermediate, or high risk? Stage 1A, grade 3, no LVSI and MMR and NSMP. So the correct answer is intermediate risk. Congratulations to most of you. Sumina again at the top score. Treatment for loco-regional recurrence of endometrial cancer in patients who did not receive adjuvant radiotherapy after their primary surgery is vaginal brachytherapy only, EBRT plus vaginal brachytherapy, EBRT only, or surgery. For recurrence, loco-regional recurrence in patients who did not get RT after surgery. The correct answer is preferably EBRT plus minus vaginal brachytherapy. The first line standard chemotherapy regimen for adjuvant treatment of endometrial cancer is cisplatin paclitaxel 3 cycles, cisplatin paclitaxel 6 cycles, carbopacli for 3 cycles, or carboplatin paclitaxel for 6 cycles. The correct answer is you should give carboplatin paclitaxel for 6 cycles. An equal distribution of answers. Supriya coming up this time with this question. The recommended frequency for surveillance after treatment for a high-risk endometrial carcinoma is 6 monthly till 2 years, followed by yearly till 5 years, 6 monthly till 3 years, followed by yearly till 5, 3 monthly till 2 years, followed by 6 monthly till 5 years, or 3 monthly till 3 years, followed by 6 monthly till 5 years. So it is for a high-risk group. Correct answer is it should be 3 monthly till 3 years, followed by 6 monthly till 5 years. Most of you have got it wrong this time. The keynote study evaluated the efficacy of DASH for the adjuvant treatment in endometrial carcinoma. Pembrolizumab, lenvatinib, lenvatinib plus pembrolizumab, or letrozole. The keynote study. The correct answer is it evaluates both the combination of lenvatinib as well as pembrolizumab for the adjuvant treatment. So Supriya taking the top notch here at the end of round 2.
I invite Dr. Nasia to take over, madam.
Thank you, Dr. Rajesh. Which of the following gene mutation is unique to cause alteration in non-endometrioid endometrial carcinoma? Nine answer till now. 26 answers are increasing. So it is TP53. P53 is the most common mutation that occurs in non-endometrioid carcinomas. Supriya is leading, followed by Sumina, then Vikas and Nikita. Next. Which of the following is false about Lynch syndrome? You all know Lynch syndrome is associated. So whether it occurs due to germline mutation in MMR gene, absence of MSH2 and 6 protein excludes Lynch syndrome, it accounts for 10% of MMRD endometrial cancers, or 50% of women with Lynch syndrome, they develop endometrial carcinoma. The answer is absence of MSH2 and 6 protein doesn't exclude Lynch syndrome. So it is false. Next. Now Sumina is leading, followed by Supriya and Vikas. Following is false about the molecular classification of endometrial cancers. P53 abnormal subtypes have high copy number. MMRD indicate intermediate prognosis. Patient with both pole mute and P53 should be considered P53, or molecular subtype cannot change staging in stage 3 and 4, which is false. So pole mute and P53, this is multiplier classification in which you depute is at pole mute, not P53, though P53 is aggressive. Now, Sumina is leading, followed by Supriya and Vikas. Which of the following investigation is not under the Transport Tech rainbow program. Number one, adding PARP inhibitor in MMRD mutation, whether MMRD needs immunization. In NSMP, hormone therapy addition will benefit, or pole mutation needs any observation, which is not under investigation in PARP. It is adding PARP inhibitor in MMRD mutation. Adding PARP inhibitor is being investigated for P53 mutation, not for MMR. So it is not under the investigation in Transportec Rainbow program. I think it's difficult. Now Sumina is leading, followed by Supriya. Which is low risk group for endometrial cancer? Number one, stage 1B MMRD plus low grade plus lymphovascular LSVI negative, or stage 1B NSMP with low grade with focal LVSI, or it is stage 1A NSMP with high grade with lymphovascular LSI negative. It is stage 2 pole mute endometrial carcinoma with no residual disease. Pole mute even in stage 2 is low risk. Sumina is still leading. Involvement ovary can occur in stage 1A3 along with which of the following criteria? Myometrial invasion more than 50, substantial LVSI, absence of additional metastasis, or bilateral ovarian tumor with capsular breach. In which case you depute stage 1A3 with ovary involvement. Absence of additional metastasis. If there are metastasis, then it will be more, stage will increase. Now Sumina, now Vikas has taken second position, followed by Supriya. Sumina is still rocking on first position. Micrometastasis in lymph node is the size of less than 0.1 millimeter, 0.1 to 0.2 millimeter, 0.2 to 2, or 2 to 4 millimeter. Five seconds left. It is 0.22. Mostly it was answered correctly. So it was easy. Now, Sumina is still on top, followed by Vikas and Supriya. In Transportec Rainbow Umbrella trial, blue denotes what? Addition of olaparib in P53 mutation, whether MMRD needs immunization, progestin therapy in NSMP, or no adjuvant treatment in pole mute. Blue means don't go with the color of options. It is no adjuvant treatment in pole mute. It is blue trial. MMRD, it is orange, and P53, it is red. But in this, the color is not according to the answer. Sumina is still leading, followed by Vikas and Supriya. Which of the following group of endometrial carcinoma need no further radiotherapy after surgery? Stage 1, grade 3, pole mute with LSVI. Stage 1A, grade A, no non-endometrioid carcinoma. Stage 1A, grade 3, MMRD, or stage 1A, grade 1, NSM. The correct answer is stage 1A, grade 3, pole mute. In all the pole mute, in the previous question, pole mute need no further adjuvant therapy, no radiotherapy, no chemotherapy, nothing. Sumina is still on top. True about endometrial carcinoma screening. More than 50% of cancers have abnormal pap tests. Endometrial cytology is useful in asymptomatic high-risk population. Screening is justified in the family of HNPCC, hereditary non-polyposis colorectal carcinoma. The answer is screening is justified in family of HNPCC because they come under Lynch syndrome. It is not for high risk, all the high risk population, all the patients who are taking tamoxifen. It is only for hereditary cases. Sumina is still on top. A rare autosomal dominant condition caused by PTEN mutation associated with increased risk of endometrial carcinoma is Lynch syndrome, Cowden syndrome, corpus cancer syndrome, or non-polyposis syndrome. It is Cowden syndrome. PTEN gene mutation is related to Cowden syndrome and they have risk of endometrial carcinoma, not Lynch. Sumina is still on the top, followed by Vikas and Supriya. Total content of LNG in Mirena, the easy one, 32, 42, 52 or 62 milligram. I think everyone has got the right answer ticked. Just 52 milligram, sorry. Sumina is still on top, followed by Vikas and Supriya. Then R. Patnaik and Nikita. Ball electrode dissects endometrial depth up to how much? 2 millimeter, 4 millimeter, 8 millimeter, or 12 millimeter. It is 4 millimeter. Okay, not 2, 8, or 12. Sumina, Vikas, and Supriya, they fixed their position. Endometrial ablation is least effective in AUB-A, AUB-E, AUB-O, or endometrial polyposis. It is AUB-A. A means adenomyosis. In adenomyosis, ablation is least effective. It is effective in endometrial hyperplasia. Endometrial polyposis is also a form of endometrial hyperplasia, as well as ovulatory AUB, but not in adenomyosis. Above 3 position, I think all the 5 positions are now fixed. Score is increasing. Which one of the following is non-resectoscopic technique of endometrial ablation? We usually use a hysteroscope or resectoscope, but in which condition, like either ND-YAG laser, RF bipolar probe, radiofrequency electrosurgical resection, or roller barrel electrode? Oh, not laser. Bipolar probe can be used without a resectoscope. We are not using resectoscope. For laser, you have to use a resectoscope. But bipolar probe can be used like thermal ablation. It is used without a resectoscope. It was the practical one. So all the questions are over. Thank you all for attending this quiz. Now look at the scoreboard.
Thanks, Nasia madam and Palani for this wonderful quiz. We'll see the results now. We have at position Dr. Supriya. Congratulations, Dr. Supriya.
Supriya is on
Vikas.
third.
Yeah,
Vikas is
second.
on second position. And Sumina. Sumina is the winner of today's ICOG quiz. Congratulations, Sumina. Congratulations, Vikas and Supriya. And please, Sumina, Vikas, and Supriya, unmute yourself one by one and introduce yourself. We want to know you, from where you are.
I think they are not in the speakers link, madam. So they may not be able to talk.
Okay.
So request you to leave a message with your name and phone number as well as mail ID in the chat box or question and answer session, please.
Dr. Rajesh, just one thing I want to tell you. Have you taken the screenshot of the scoreboard? Because we have to note down the winners. Sumina first, then Vikas, then Supriya. And we also want to know their mobile numbers, their email IDs, and all the affiliation. So they can write in the chat box and you can know.
So hope anybody can send, or I leave my phone number in the chat box. Please WhatsApp me the details, the top three.
And thank you for participating. Thank you, Dr. Rajesh. You conducted it very well. You posted this on Kahoot, which is a tedious job. And you also put some pictures. So thank you very much. Thank you, Apala, for being a part. Do you want to say something, Apala?
Yes, ma'am. Thank you for having me as a part of such a prestigious program and making the questions as well as conducting them. As opportunity was huge for me for learning, teaching, and as a whole. So thank you, ma'am, and thank you, Dr. Rajesh, for having me here.
Thank you, Nasia madam. Thank you, Apala. Thank you, ICOG team. I think the organizers are already winding up the program. So I have left my number in the chat box. I hope the winners will contact or message your numbers on the mail ID so that ICOG will be sending you the prizes. And with that, I think we'll wind up. Anything from the ICOG team? I think I was asked to wind up the program. So at the back end, I thank all the participants who has been here and the committee, ICG committee, all the organizers, and I thank everybody, the faculty, chairpersons, and the Zoom platform which was provided. Thank you, and we'll thank you.
Thank you, everyone. Bye.
Yeah, thank
Yes, Tulsi, please.
thank you so much, everyone. So from here, I'm ending this meeting. Thank you.